Hi, Andrew.
Hi, everybody. Thanks for having me on, and thank you all for putting on this wonderful event. I'm just going to share just a few words from our perspective here at Catalyst. Do I sound okay? Everybody hearing me okay?
Yep.
Okay, fantastic. Just give me some cues until we get this perfect. Okay. So Matthew, I just need a bit of a favor from you. If you check your email and download some slides, if you can screen share for me.
Okay. Now you tell me to.
So thank you again. I just wanted to say from the perspective of Catalyst that we're really excited to support this event led by Adam Culbertson and Megan Antonelli. As we know that this is just a continuation on a long journey of doing incredible work with this community, and wanted to just share a few updates from our perspective and how we're here to be a resource for this community going forward. So I don't know how many of you, just for background purposes, I think a number of us on this phone call know Matthew and I from quote unquote Health 2.0, but I'd love to give a brief update on what we've been doing since then. So after we have sort of run the conferences that many of you have been a part of, we now are full-fledged running a component of our business called Catalyst. And Catalyst runs a number of innovation programs that I want the folks on this phone call to be aware of. And it actually ties specifically into what Dawn is going to be saying in a few minutes to all of us. So we are involved very much in connecting this community to opportunities that need your services. And so Matthew, if we can just go straight into just some of the Robert Wood Johnson slide. Yeah, we'll just go really quickly. And so just so you guys know, we are, yeah, go straight to that. We want to call to your attention the opportunities to get involved in some really exciting developer challenges. We've run over 15 of these over the years. You've probably seen announcements for them, but we can't say this formally just yet, but in the coming weeks, we'll be launching our next challenge with Robert Wood Johnson, and it will be focused on the technology community's response to pandemics. So please stay closely involved and following in whatever role you're playing in the community, whether you're a developer, whether you're a provider, a patient advocate. We need everybody to be involved in a number of these efforts, and this is just one of them. So this is coming in the next couple of weeks. Next slide. We also want to let you all know that we have active projects now with the World Bank around the world looking to partner digital health companies with healthcare organizations. We're running 20 of these pilots in Brazil right now, and we have just gotten word that we will be doing this in East Africa. I know this is a time when as a globe we're thinking very much about travel and limiting and restricting, but there is active work going on around the world still, and we really want to put these opportunities on your radar to get involved as those call for applications go on. The IDIH project is a European Commission project. Some of you on this phone have been tapped already to be experts and contributors. This is around how we age healthily around the globe. It's a partnership of multiple sets of countries from Asia to Europe to the United States, North America. So stay involved for that. And this is a project I also wanted to let people know about. This is such an important need. I live in California. As many of you know, our state has put out a call for digital health companies who are working in mental or behavioral health. We ran the first round of a call for applications for this program. Over 110 companies raised their hand to help out. Please stay tuned for more of this. We need all the help we can in our state as well as the rest of this country, but this is specifically a program supporting the 55 counties in California. And last but not least, before I hand it back to Megan and Adam, we are really excited to announce a partnership with HL7 and the ONC to work on a new survey for those using the FHIR standard. So we're at this time working on vetting down a list of people to invite to this first round of interviews for feedback and input. This is informing HL7 and the ONC about the current usage of the standard, barriers to adoption, ideas that actual users in the community have to improve this. So we will be releasing a call for getting involved. But right now, today, we will be putting up two form stack applications, actually one, if you want to be notified and invited to give feedback on your use of FHIR, your experience with FHIR, please get in touch with us right now. We're collecting those names for these interviews, and that will be extremely important to the ONC and HL7 as they update their survey for the broader community. So thank you so much for having us. And you will see in your chat window of the Zoom, please take down that link that Michaela has just put on and indicate your interest there if you're currently working with the standard or would like to just know more about this project. So thank you so much, Megan, and thank you, Adam.
Awesome. Thank you, India. That was great. As we move in, I think we're just waiting on Dr. Rucker to share his screen, correct?
Are we sharing the screen now?
There we are.
Okay. Let me know when you want me to go.
So I don't see you yet. I see HHS TV studio.
I think they're still seeing the studio and not the camera.
There you are.
Okay.
Fantastic. Welcome. Thank you so much for joining us today.
Oh, my pleasure.
And you're coming through clear, so go right ahead.
Okay. Well, obviously, application programming interfaces is one of the things in the news these days. And I think one of the more positive things, as folks know, ONC and CMS recently released rules under the our rule was under the 21st Century Cures Act. And that act was designed, amongst other things, to really allow an app economy to start and flourish in healthcare. That really was, there's an entire section of the Cures Act dealing with that. Title IV for folks who are students of the legal sphere. And what did Congress want? How did Congress look at this? And what do these rules put in play? Well, Congress really looked at APIs and wanted application programming interfaces, so APIs, and wanted APIs without special effort. So what does that mean, right? So that is one of the things that we had as a federal agency charged with writing a rule, come up with how to operationalize that. The other big part that Congress wanted in there, which is really at the heart of what we're talking about here today, is Congress wanted to guarantee patients that they have the right to their data, that this is their data and it shouldn't be blocked. So Congress put in provisions around what is called information blocking. And as we sit here today, Congress actually has outlawed information blocking. Now, that's a very broad construct. So ONC was charged with having allowable exceptions to that. So in other words, operationalizing the concept of information blocking and putting up some rules for the road, right? It's sort of almost like deciding, where are the lines on the highway? Are you, driving on the right-hand side, left-hand side, that type of stuff. So let me talk about each of those important provisions, and then the audience can reflect on how they can respond to this world, I think, because that's the whole goal here. So the API provisions, the technical provisions, are under our certification program. And what we're really asking of folks is, and requiring, are that electronic health records have a FHIR-based API. And 2 years from now, that's the deadline date, to have a FHIR-based API. We're starting with what's called the US Core Data for Interoperability to keep this manageable and to be able to have all of the EHR vendors be able to do this. And so that US core data for interoperability, the API, you can think of really from a computer point of view as having a database driver hooked up to a server that then goes to the internet with all of the sign-on and security protocols there. So that is the core of it. And you might ask, well, look, we've been trying to do interoperability for decades, right? Decades and decades, really, when you get right down to it. What's new now? Why now? What's different? I think we can look at a couple different things. I think, first of all, we actually have electronic health record data now over the last number of years. We certainly have the compute power and the memory. We certainly now, with the internet, have the networks. And finally, with the RESTful, JSON, and then the healthcare adaptation of that technology stack, FHIR, so fast healthcare interoperability resources, we have, I think, an elegant way of doing these APIs that are open really to lots and lots of programmers. In the past, we had APIs, but you really had to be a bit of a student of the black arts of healthcare interoperability magic to use these APIs. Now we have APIs that I think are more elegant and in keeping with the rest of the app economy. So that's an important provision there. For the 2 years out from now, those APIs will be part of our certification program. 3 years out from now, and we've extended that deadline, we're going to also require export of all data. Obviously, all data may not have clear standards, so that'll be just tagged with dictionary things, though maybe standards will evolve there. The other API that I want to talk about just and mention is we're also putting in under the FHIR version 4 has an API for bulk or population data. Maybe we can get to that in the questions, but that's more really between counterparties in healthcare, sort of a B2B type of thing between covered entities and business associates. The APIs we're really focusing on today are the ones that are out to patients and their apps. We think this is going to be absolutely powerful. Nowhere else in the American economy do we not give and let adults have information about their decisions, their important life decisions, whether it's your banking or your insurance or buying a house or buying a car or traveling. Everywhere else, pretty much, shopping, you have information on what products cost, what those products are. In healthcare, we have not had that. We think that these APIs and the Cures interoperability rule will actually do that. The CMS companion rule to the ONC rule asks the same of payers. So claims data can be put into this mix to increase the transparency. The president has signed an executive order and there's rulemaking in process for price transparency. So all of these are really coming together in what I think will be an extraordinary consumer experience. However, in order to do that, Congress also said the data has to be shared. So what Congress said is that information blocking is outlawed. What does that mean? It really means that you have to allow patients to get at their data. And in order to make this practical, we've put in rulemaking a couple different things to protect the privacy and security of this data, which is critical, and then to also address some of the economics and some of the timing there. So let me talk first about what we're doing in the rule with privacy and security. When in the rule now, and over time this will change because the technology of how we authenticate to apps is changing. But in the initial go around, you will, if you want to get your data onto an app of your choosing, you will log onto your provider's portal, right? Same security as now. And then in a process called OAuth 2, you will give consent to whatever FHIR resources you want this app to have. To make sure that you understand that here we're talking about the HIPAA right of access, which has historically not really been a computer thing. It's really been getting your paper medical record type of activity, so that the public understands they are removing the data into their control, the providers will be allowed and in fact encouraged to have a clear warning, you're removing your data from HIPAA. Also, what we're having here is a requirement that the providers can say whether the app has a consent policy, a plain language consent policy or not. So folks can be clear on what they're consenting to. The nature of this process is a legal contract. And what that then means is that if the app has not been straightforward and honest in what they're doing with the data, they actually can be prosecuted by the Federal Trade Commission under deceptive business practices. Competitors can come in under unfair business practices and complain. And in many states, roughly 20 states at least, there are causes of private action. So we have something that is modern technology, the same APIs that you would use, let's say, for your bank account, right? You're depositing a check. We have those now in healthcare. The information blocking part to make sure this works and is secure is providers don't have to give the information out if they're worried about a privacy risk or a security risk, or if they're worried, they just don't have there's a temporary shutdown because they're, updating the server, those types of things. If there's a possibility of harm. In those cases, we're not going to put patient data at any risk whatsoever with those protections. The other part of information blocking, to make information blocking real, is that these APIs have to live economically. So historically, we've heard a lot of reports where EHR vendors will charge vast fees totally out of proportion to any cost because they essentially have almost, you could call it almost a ransom on the patient's data, just by the happenstance of being the EHR vendor. The ownership of patient data, when you play it out legally, the people who have ownership rights there are the providers who generated the data, the patients and the payers. So we want to make sure that those folks actually have access to what they own. We have put in, to make this practical, we have put in some limitations on allowable fees, but we want to encourage entrepreneurs, we want to encourage the economy. So absolutely reasonable profits. This is not a nonprofit activity. We want people to do this. We want them to make a good living. So we have absolutely allowances here for profit in there. To make it practical technically under information blocking in the rule, we've done a couple things. This is, truth be told, a new legal concept that Congress has presented. And so for the first 6 months, there's absolutely no enforcement. We're, putting this as a learning period. The enforcement realistically won't start for a while after that because we haven't put in those rules to define the parameters of the enforcement process. And up until month 24, just to get people started, the only data that needs to be shared, again, is the US core data for interoperability. So we're talking about medication list, allergy list, problem list. We've added in clinical notes. That includes diagnostic imaging notes, not the images though. That's some point down the road when we all have more bandwidth nationally that we can rely on. Some provenance data to allow for better matching and demographics. So for the first 2 years, that's what the expectation is that you would share. After that, we have, all data can be shared. In order to make the sharing practical as we're moving into this and as developers are evolving, we've put in what sounds a little bit of has a funny name to it, but it's called content and manner. And so what that is really, content is what do you have to share, right? And we've just outlined that 24-month transition point from the core data to all of the data in the designated record set. And then manner is how you share it. Obviously, some people have FHIR APIs today, but this is really a work in progress in terms of the EHR vendors. So initially, you really can share it in any way you want, and you can actually charge any price for that if there's mutual agreement between the various parties. If they cannot reach mutual agreement, if there are standards that they can use those standards, or ultimately, if not, in a machine readable way. So that's a lot of legal construct and language to make this real. You have to put those things in to make this operational for patients and app developers to do. We've done that. We've reflected on 2,000 public comments. The rule is around 1,200 pages. If you look at it, and we have all kinds of information on the healthit.gov website, so you can get the flavor of everything I've just described without reading the rule, if you will, the Cliff Notes. And so what we've done there is to make this operational so that patients really can benefit from this, and app developers can really get some great things going. We've done it in a way to minimize the hassles for providers. Essentially, providers are putting up a endpoint to their EHR with security provisions. There's nothing that they need to, I mean, they have to do that, certainly, and there's effort involved there, but there's no maintenance, there's no live maintenance. So we think it's a relatively straightforward process. So that's what we've done. Now, what is going to happen here, right? So we've done all of this. What's the goal? What do we think is going to happen? We think there are going to be two big phases here. The first phase is just the phase of transparency. Patients get their data. Apps will be able to assist patients with thinking about their medical care. They'll have the medical records on their smartphone. We, plan on this being coupled with price information. So finally, the American public are going to be empowered consumers about their healthcare, the way we are in the rest of our smartphone lives. We've never had this in healthcare. That is really the first big step. But the second big step, as Indu and Matthew have sort of alluded to, and in the Health 2.0 conference have shown many times, is that's just the first step here. Really, it's not just getting the data onto your smartphone in a passive way. It is really looking at the smartphone as a tool, as a computing platform that opens up an entire new Internet of Things. So because once you have the data, then you can do any computations on it, because now the patient is, to use a pseudo legal term, the agent. They have agency, they have control. So they can put any kind of computing products on there. You're already starting to see, often without that clinical information to really backstop it and make it great, glucometers, heart rate monitors, peak flow meters, digital blood pressure cuffs, digital scales. But all of those things, I think, are just the start, because I believe that the cures rule will really allow us to look at chronic disease in a different way. Obviously, today, as we speak, we're in the midst of an extraordinary acute illness, a pandemic, and we hope, obviously, that this, in a funny kind of bizarre way, continues, but that most of us lived long enough that where our real risks in general are chronic diseases. How do we treat chronic disease today? We have, you have episodic care, you have an office visit, maybe you have a hospitalization. With smartphones, we can take the care of chronic medical conditions from acute episodic events, use the smartphone, which we have on us for better or worse, pretty much all the time, and use the tools and the harvest of modern technology and the entrepreneurial economy to think about ways to interact with that smartphone on testing, diagnosis, behavioral modification, so that we're enveloped in care continuously. It's extraordinarily exciting. I think it's a modern way to do care. We are very excited to be part of that. I think the administration has high hopes that this really is what we've talked about fundamentally empowering the American public in ways that are, absolutely transformative. So I think with that, we have some time for questions. I don't know how we're doing on time, but if there's time for questions, I'll take guidance from the moderators.
Adam, this is Shahid. Do you want to read out the questions to Don?
Sure. So question 1, Don, is how will users be identified and authorized for the bulk API access?
So, so to be clear, let me just be very clear, because I think implicit in the question, maybe I wasn't clear enough. So the consumer part, where this consumer authorization authentication comes, is under the HIPAA right of access. The bulk is simply a more efficient way for people who are communicating today to do it with, you know, a more modern technology stack. So that is entirely under the current cures, treatment payment operations, permitted uses of patient data. And so what that means is, let's say a doctor's office or a hospital have a signed contract with a payer, maybe an analytic firm. So they'll use, you know, the passwords and network protocols they're using. What's different about bulk, as we're building out this world of FHIR, is right now, everybody talks about big data, right? The audience on this webcast has probably been inundated with presentations on big data. There's actually no API to do big data in healthcare. Every time you hear about big data in healthcare, it is almost invariably 1 or 2 hospitals, and they're almost invariably custom queries. What we're saying is, technically, in ONC's role as a standards organization as well, ONC has a number of different roles. We've talked a bit about the regulatory, but we do obviously support standards. We're just saying, while we're doing all of this work on FHIR, let's put out something that allows population level FHIR and makes that so people don't have to rewrite queries, custom queries every time they do that. So that authentication is assigned, all goes from signed contracts between payers and providers and any other parties. Those are typically the 2 parties that we expect initially to mostly use this. A lot of providers may just use this internally, frankly, but they will use whatever their current network protocols are.
Thanks. The next question is, does this rule make it easier for more affordable for app developers creating clinician-facing apps to access and utilize US CDI? Before, this was only available by signing up for a vendor's developer program, which can be costly for an innovator.
Yes, we think this makes it materially easier. So I do have to point out, all right, so part of public policy is the art of the possible, as opposed to some alternative. So what we are doing initially are read-only APIs, right? And as you heard, and as the question incorporates, we're doing the US core data for interoperability first. That will, over time, evolve and expand. There are provisions downstream for all data, export of data under the information blocking and certification provisions of the rule later on, but it is a read-only. So that part of it, the EHR vendors have to make publicly available. They have to make the APIs available. They have to make the documentation and whatever tools are needed, you know, Sandbox, for example, to allow that to happen. And those are where the various fee restrictions would come in. So for patients, they get their data under the rule, they get the data to their app for free. Obviously, we don't want to put the providers into a position where their API purchases are vast. So we have rules around what are the allowable charges there. However, if it's something outside of that, so read-write APIs, you know, special app store co-marketing services for that, because again, we want a vibrant market economy that is to be negotiated with the EHR vendors on market-based terms. So it's a little bit of a complex dividing of things, but we have to ultimately balance the rights of the vendors, the rights of the public who own the data, the rights of the providers, and all of the operational issues that play in each of those spaces. So that's what we've done based on all of the feedback we've gotten.
The next question is, let's see. Please address perspectives on legacy standards such as CDA, CCDA, XDS, XCA in light of FHIR. Are these legacy standards no longer recommended to be used?
Well, so there, you've mentioned a number of different standards there. I think some of these things will evolve. Some of them, like the CDAs, the document architecture standards, I think they tend to be a little bit more of a texty standard. You know, people have built up things there. We hope that those things will, I think eventually some of them will morph over time. All of this is a process where people decide ultimately where they want to invest, where the value is. We've tried to be as minimally interventionist here as possible. I know some will say, what do you mean? You've just put out a large rule here. But when you really read through the details, I think you'll see we've tried to put in realistic timelines. So for example, the health information exchanges who use some of the standards you just mentioned, you know, they would go along with those, I think, for a while. SHIC, the organizing group for the HIEs, is looking at how they're going to move things. I was scheduled to do to meet with an international IHE conference this in the coming days that got canceled because of travel restrictions. But I think these things will move in progress. And as with all of computer science in every field, we're going to find, you know, what is the balance between tightly structured data, loosely structured data, unstructured data. I look at these as sort of points on a continuum, frankly, as we think about this. As folks know, probably, you know, you're going to be using different software tools, different techniques, depending on what the questions are and what the data that you want to analyze, what the format is.
Let's see. The next question is, US CDI is very focused on clinical context. How do we expand US CDI to embrace the needs of the payer community? They often use special value sets that aren't covered in US CDI.
Yes, so we're in the middle of some very early discussions on how to think about merging clinical and financial data. As was just pointed out, the financial data largely starts in the X12 world. We have had discussions with pretty much all of the relevant stakeholders in that world. So starting with the National Center for Vital Health Statistics, Bill Stead as a chair has realized the same thing we've realized and that the questioner has realized, which is, how are we ever going to pay for value in healthcare if we have a total disconnect between financial data and clinical data, right? It doesn't make any sense. Could you imagine online shopping if the price and the product description were inexorably not connected? I mean, it doesn't cohere. So we've had discussions with the folks in X12, with CAQH, with WEDI, a whole bunch of folks who are involved here, the CMS standards group. There are a number of parties here. I think, we'll see how this all plays out. I think you can imagine a world where some of the FHIR clinical information is grafted onto the X12 flows to minimize the economic disruption and start putting these things together. And you might say, well, okay, value, buying value, I get it. We think some of these, looking at this, looking at the population level data, are really going to be the heart to reducing a lot of provider burden. Right now, we have bad ways of, bad mechanisms, I should say, in terms of how we assess what we're paying for. So we've had a lot of very goofy documentation requirements. CMS under Administrator Seema Verma and we've been very happy to participate in that. We've been working on clearing up the documentation requirements so that doctors' notes and clinicians' notes and nurses' notes actually mean something, as opposed to just being, billing boilerplate text. We see as we merge these data streams that we can probably totally rethink the need for prior authorization, which is, again, a hack, if you will, on non-market-based, non-market price payment things, mechanisms, and frankly, quality measures fit into the same bucket. Imagine a world with population level data and pretty much any machine learning algorithm. You can take the data, payers have a right to this data now, even if they've operationally not had access. And you can use modern machine learning tools and totally obviate the need for these one-off, custom, heavily gamed, heavily politicized quality measures as these APIs advance. So you can see a very different, very much more seamless, very much more low friction, right? Because all the money we spend on these sort of overwrought payment mechanisms basically is coming out of the American public's pocket. So I think APIs are going to be very powerful there, even beyond the transparency and changing the nature of care. APIs cause revolution wherever they are. If there's a space that needs rethinking, I think American healthcare is pretty near the front of the line.
Thanks, Don, and thanks to HHS for all the great work you guys are doing. Also, fighting this pandemic. We're gonna. Oh.
Yep, thank you very much. We've been very, very busy with all the pandemic work here. So absolutely.
And I'll turn it over to Megan.
Oh, great. Thanks, Adam. Thanks, Dr. Rucker. So appreciative of your comments and sharing your time with us. I see David Lee is here. David's a director at Levitt Partners, and he's going to respond and give us a little of, the implications of these rules on providers and payers. Thanks. I'll turn it over.
Yeah, and it's great to, thank you. Great to be with you. And a big thanks to Dr. Rucker for his leadership here and moving this rule forward, and to CMS for moving their rule forward as well. So Levitt Partners helps run what is called the Caring Alliance. And the Caring Alliance is a group of multi-sector stakeholders who have come together to advance consumer-directed health information exchange. And we've been around for about 4 years. We were started by former officials from the Bush and Obama administrations who in a bipartisan way came together to say, we need real interoperability. We need to push forward in meaningful ways the ability for consumers to get their information and to use it to accomplish their healthcare goals. And so, today we had an op-ed in Fierce Healthcare from two of our founders, former HHS Secretary Mike Levitt and former Chief Technology Officer for the United States, Anish Chopra, who talked about how great these rules are and how excited we are. But I think as Megan teed up, this moves now from not just getting the policy right, but moving forward in significant ways to make sure that these are operationalized and that they are meaningful, both for the data holders, for providers, and for plans. But then I think, as Dr. Rucker talked about a little bit, for the consumer as well, to make sure that a consumer has appropriate access and appropriate safeguards for their privacy. So I'm going to talk about a couple of the things that we're undertaking to try to make this a reality. And I'll note that the Caring Alliance is one of several what are called HL7 FHIR accelerators. So I'm sure that many of you are aware that Caring Alliance and Da Vinci and Argonaut and Gravity and Codex have been pulled together really under the leadership of various folks, but facilitated by HL7 to advance a number of use cases and implementation guides. And so I want to start off first with the compliance perspective or the implementation perspective of the CMS rule, and what Dr. Rucker was talking about at the end of his comments around implementing and allowing consumers to access a lot of their claims information and the ability for plans to implement a solution. So as was talked about, the implementation timeline for the CMS rule, where the plans have to make available both the Patient Access API and the Provider Directory API, will be January 1st of 2021, which seems like a pretty quick turn, except for the fact that, again, Caring Alliance and DaVinci and others have been putting together implementation guides to help plans go into production by that deadline. And so noted in the CMS rule, they point to a number of technical resources on their page, and included in that is the Karen Blue Button or Common Payer Consumer Data Set implementation guide that should be hopefully an out-of-the-box solution that they can plug into their systems and help consumers get access to the claims information that are required for plans in January 1, 2021. I know Amol Vyas is on the call from Cambia, has been a very critical architect of that and moving that through the SDO process at HL7. So flag that piece from our perspective is critical. One of the other areas that we want to focus on as well is the consumer protection and privacy components of this. And I know Grace is on, and ePatient Dave will talk later in the program, I believe. And so many consumer advocates who have done such great work in making sure that people can get their information and can get access to their records. And the reason why these rules are so important in our perspective is for the consumers, the patients, the caregivers who haven't had access before and haven't been able to coordinate their care and haven't been able to really work across their disease states or their providers. I had a very interesting experience when I moved my family across country 3 or 4 years ago in trying to get some immunization data from our pediatrician, and these rules should help facilitate that so that next time I don't have to go in paper format. It doesn't take 3 to 4 months, and we can get that information and move things very quickly. But one of the areas that we continue to hear about is consumer privacy. And we were, I think, excited to see some of the modifications in the rules that would require providers and plans to provide more educational resources to consumers when their data is moving from a covered entity, which is governed by HIPAA and all of the safeguards that entails, to an app or a platform that's now going to be covered by the FTC in Section 5. What does that mean? What new activities do consumers need to undertake? What are the things that they need to do to help safeguard their own data and make sure that they are being responsible stewards of that data? And so, the two things that Dr. Rucker talked about, the warning that your information is leaving HIPAA, and then the statement about whether or not an app vendor has voluntarily attested to some specific vetting process or code of conduct or the like. And again, in the CMS rule, they did point to the Karen Code of Conduct that we have developed, again, with about 85 stakeholders, consumer advocates, non-HIPAA technology platforms, providers, payers, to try to make sure that apps that are getting data out and are holding this data for consumers are doing so in meaningful ways and being transparent about how they're using that data and providing those value-add services. So I think, Megan, you had asked about timelines and what this means for the consumer and what this means for privacy. I think that the timelines are aggressive. I think the timelines are needed to make sure that the industry moves in appropriate ways. I think that there's going to be a lot of work to do and getting ready for January 1, 2021 for the payers, for getting ready in 2 years on the ONC information blocking, and then 3 years as the data sets expand, as state Medicaid agencies are required to share more data back with CMS in that rule. So a lot of timelines, a lot of work to do, but I think we, as the Karen Alliance, are excited about the opportunities for consumer data exchange and consumer direction of where their data goes to make sure that they're able to accomplish their goals. So I know we're a little short on time, so I'll stop there to make sure that we can answer any questions from folks on the line. So Adam or Megan, if you have any questions. Yep, go ahead.
Yeah, thanks so much, David. I mean, there's a couple questions here. I think we've got one that in terms of the consumer-facing FHIR apps and working with individual EHRs and providers to have their apps trusted and certified. That might have been one for Dr. Rucker, but is that something you feel comfortable answering?
Yeah, so in the CMS rule and in the ONC rule, it talks about things that providers and payers and individual EHRs can and can't do with making an application available for consumer use. So he talked, and Dr. Rucker talked about this a little bit as well. If an app is going to expose the underlying technology system to some undue risk, then a provider or an individual EHR or a plan and their accompanying technology system can deny access. Otherwise, they can't deny access to that application. Again, this goes back to the consumer's individual right of access right under HIPAA, and if they want to use that app, they can use that app. They did in both rules talk about a little bit the requirement now for plans and providers to provide a little bit more education. And again, what does this mean? There's a recommendation in the CMS rule, at least, that plans do create some interview questions. What are you going to do with this data? How are you going to safeguard the data? Do you sell data? And those types of things that they can recommend as a voluntary attestation when an app comes to get API access. If the app declines to fill out that vetting, the plan can't, or the provider can't deny access to the app, but the provider or plan can provide that as an educational piece to a consumer who's looking to use that app. Hey, look, we asked them to attest to certain industry standards on the code of, or on how they were going to use their data, and they refused. So that should serve as a warning sign for you that this app may not be have the best intentions. So with that, and I think Adam, you put in the chat, talk a little bit about the Karen Code of Conduct and what that entails and what we're trying to do potentially with a Karen app gallery moving forward. So the Karen Code of Conduct, again, was established by 80+ organizations that walks through what we believe are industry best practices for consent-based sharing of information. So these are attestations that we ask apps to make about what information they're sharing with the consumer. We never want to cut off access if a consumer wants to use a specific app. That's their right, that should be their choice. But we do believe that there needs to be sufficient transparency so that a consumer knows what an app is going to do. So questions from the Code of Conduct include things like, have you disclosed how and when and if you will sell consumer data to third parties? What are your consent protocols for getting affirmative, proactive, opt-in consent for data sharing? There are some very hard and fast rules. Do you comply with industry best practices for data and security? So those are the types of things. And again, CMS pointed to the Code of Conduct as an example of things that payers can ask an app when they're looking to get access initially, and what an app should be attesting to. We believe from an industry best practice perspective of how they're going to use information, what disclosures they're making to consumers, what security protocols they have in place, who you can contact at their business about questions and the like. On the app gallery side, our hope is to create a vendor agnostic app gallery where apps can go and list themselves, answer a few kind of preliminary questions, and then post themselves on a public website where patients can go and say, I want an app, as Dr. Rucker said, that's going to help me get more steps in a day and integrate my clinical record with a weight loss app or something like that. And the hope is that as we continue to build this out and go live with this in the next few weeks, that consumers can go to a place that's not tied to a provider, not tied to a vendor, and really pick an app that's right for them, that has attested to the Code of Conduct, and they can work through those things.
Awesome. Thank you so much, David. That was great. I will hand it over to my friend Shahid Shah, who will take the patient perspective and talk with ePatient Dave and Grace Cordovana.
I have to interrupt. Dave, what are all those medals?
Those are just from running. Those are just from running, Dave. But thank you.
Great. Thanks, David Lee. So we've got ePatient Dave and Grace coming on. So Dave, Grace and Dave, can you guys go ahead and jump on now? Are you guys there? All right, so while they're joining, I want to talk a little bit about what this section of the, so it looks like Megan, David said he just needs to be let in. There you go. All right, hi there, Dave. And Grace, I think, probably needs the same permission. So what I wanted to spend a few minutes on is taking a look at these new rules and very specifically trying to figure out what can patients really do now that they weren't able to do before. And of course, because it's still 6 months away from any immediate implementations, how do we on the patient community side help patients prepare and get going with new ideas, new techniques, new technologies to help them understand what new capabilities do they have now coming forward. So with that, I'd just like to, many of you already know ePatient Dave and Grace both because they are tireless members of the community who have been pushing to make sure that patients have their voice at a minimum. And it's pretty silly that in healthcare, we need people working tirelessly to make sure that patients have a voice, but it's necessary. So what I'd love to do is so that you guys introduce yourselves a little bit and jump in and talk about what you're doing on the Unblock Health side. And I know you've got a few things to show, and then I'll jump in towards the end and facilitate questions.
Would you, Grace, why don't you go first? This is a little different from what we had anticipated.
Okay, terrific.
Go ahead.
Sure. So Grace Cordovano, I'm a board certified patient advocate working in the oncology space. I am passionate about medical records and accessing data in order to make empowered and informed decisions about care. I am going to give the reins to Dave. We have been collaborating and colluding on the best way and the most powerful way and the most succinct way to present this to you. Dave is going to present the purpose behind why we need access to records and the benefits and risks that happen when you do and don't have them. And we will talk a bit about releasing something new through Unblock Health, which is the patient impact stories. Our hope is to humanize interoperability. These words are technical and cold, and we are going to bring the lens of empathy and the boots on the ground experiences here. Dave?
Yes, and I've got to say, Dr. Rucker, I wish it were legal to buy you a coffee or a beer or whatever it is, because you speak to our concerns, and this is a big deal. Is Zoom going to switch back over so that I'm the one on the feed? In any case, I need to display my slides. How do we go about me sharing? Do you make me the magic guy, or do I have to click something? Oh, I have a share button down here.
Yep, there you go. Just
Share button.
Good. All these easy to use apps seem to be different, but it's not letting me, it's not doing the usual thing to let me pick my whole desktop. So let's see. Oh, for heaven's sake. You know, just to illustrate how much fun it is to work in the world of IT, my computer died yesterday. And so now everything I'm doing on this previous computer needs to restart. I have to recertify everything as being allowed to look at my screen. So, all right. So that means I have to quit Zoom and re-log in. I'll be right back after this message.
So in the meantime, Grace, if you can come back on, we can have a little chat about what you've been working on with a number of different organizations with respect to the new rules, what you're seeing them as. You and I have chatted about the fact that some of these rules do have you looking at them and thinking that things will finally change. but others you're not so convinced about that they will actually change for the better for patients. Talk a little bit about what you feel from the patient side about the rules that have come about. Are you feeling good about them? Not so good about them? Tell us where you are.
Sure, a loaded question, but here's what I'll say. It's a step in the right direction. I don't think we can pat ourselves on the back and say, this is a great job and we're done here. There's definitely still more work to be done. But when you look at it through the lens of being a patient and a care partner, and through the eyes of someone who's suffering a chronic illness, a life-altering diagnosis, cancer, multiple comorbidities, in order to be an empowered consumer, an empowered proactive member of your care, the common denominator is having access to those medical records. You can't schedule a second opinion appointment. You can't dispute a claim that has been denied. You can't make an educated, informed decision about your care without understanding the contents of your medical records. And this is what brings people to their knees. And it's a huge bottleneck across the spectrum. It doesn't discriminate. It doesn't matter if you're a high power executive or if you are a child that is navigating this because your parents don't speak English. I think this is a win in that category. And I want to point out too something from a patient engagement standpoint. A lot of the tools that we have in our digital tech and healthcare ecosystem are to change the behavior of a patient, to improve their lifestyle, to improve their choices and behaviors. But a lot of the times it's not the patient that's the problem, it's the ecosystem. And there's no tools out there to arm patients when there are cases of information blocking. That's something that has been a driving force behind Unblock Health, to arm patients and their loved ones when they are struggling to get access to their medical records, when the access actually means life or death. So I'm very hopeful. I think that there's a lot of people doing a lot of great things that are laser focused. And I think collectively, we're definitely going to move the needle in the short and long term.
Great, thanks, Grace. So Dave, it looks like you're back. Are you able to share your screen now?
We hope. Yes, this is much more normal. Spend so much of my life in Zoom. It's so ironic that I come to do this event, which is the fulfillment of my purpose in life. And what happens? The technology bites me. So in all seriousness, the patient's view, and I love what this new collaboration with Grace has brought, because she really does restore the heart to it. She's the one who came up with this line. It's time to humanize interop. And I don't know if you can see it, but for this occasion, I'm wearing my HIMSS Interop Showcase shirt. I guess I'm screen sharing now, so you can't, but because knowledge is power. And the purpose of this story project is to make clear how that power shows up in street reality or at the bedside or however you want to describe it. I'm known for back in 2009 in frustration after I ended up on the front page of the newspaper and I was asked to give my first keynote speech. Gunther Eisenbach, the organizer, said, "What do you want the title of your speech to be?" And I said, "I don't know, just call it Give Me My Damn Data." And what was not published, see, this became a slogan, a coffee mug, and even a music video. Ross Martin, the famous informaticist who was at Deloitte at the time, data about me. Well, what was not published at the time was that the second part of that, what I said was, give me my damn data, because you guys can't be trusted with it. And, rather than adding to physician burnout and more mandates and everything on the health system, what I want everybody to hear is you don't have to do it all yourself, Let patients be involved, but that can only happen if we can see the data. So Morgan Gleason, as many of you know, before the ONC national meeting, orchestrated a patient caregiver letter. This is the genesis of what I'm going to be showing you for the next few minutes, with a collection of stories of cases where bad things happened, because patient data wasn't under control. The paternalists say, wait a minute, you guys don't understand, bad things might happen if the data gets out of the EMR. We are here to say bad things already do happen when the data doesn't move around. And even more importantly, good things happen, as you'll see in the next few minutes, when the data does. This is humanizing what FHIR means, what all data interrupt. I'm a data geek in my career before healthcare, before my near-death cancer experience, but that's a story for another day. When these stories, when we came out of that ONC national meeting where Grace spoke on stage, we realized that these stories need to be told, and it needs to be a collection that will grow. And it's going to be growing on the Unblock Health site, as you'll hear at the end. Harm can result when we can't see and participate, but good can result when we can. Please, please, please. Yes, of course we need to manage privacy. I wish that everyone who was worried about privacy would be screaming from the rooftops about the egregious violations that Facebook is doing. If you're not familiar with that, look on Twitter for the account Be Like Light. It's a collection of people who are working to create a better alternative. Anyway, these are true stories submitted to this project. The most famous, Regina Holliday's husband, Fred, was denied pain medicine for his metastases. And I'll tell you, if you've ever had bone metastases, as I have, that hurts. He was denied metastases and food at his new hospital because his records didn't get sent along. That's a human consequence, suffering from lack of data mobility. All right, Sue Sheridan, well known in Washington health circles for her work in quality. She got into it the hard way after one of the two medical disasters in her family was that her husband died when the office staff misplaced a pathology report. She found it in his chart folder a year after he died. The doctor never saw it. See, this isn't just about patient concerns. Imagine how that doctor felt discovering a year after the patient's death that information was there, but was not brought to the point of need, okay? Here is Morgan Gleason herself, 23 portals, no doctor anywhere has the full picture. So it's left to her, she's in college now, she had to spend hours getting records from 12 of them while unwell. We can do better, okay? Here's Morgan's mother, Amy, who works in the US Digital Service. Kidney stone treatment delayed 3 days and 4 nights while the doctors tried to retrieve her records. And then we have conferences about, gosh, what is patient-centered care? What would that look like? Well, how about we make full use of all the data that was brought together over the years, caring for somebody. Kristen Valdez, who went on to found Be Well, and was on another event Wednesday, unable to get appointments scheduled until she pulled the records together herself. Okay, Adrian Gropper, well known for his interest in privacy, manages care for his mother 200 miles away. He is an MD, but he can't possibly coordinate care and avoid mistakes without data access. Janice Tufte, her mammogram showed an issue, but nobody ever told her she had to come in for follow-up. It just fell through the cracks. She's the sort of engaged patient, if she'd seen that, she would have done so, but she showed up for her next mammogram and it was denied. She couldn't because she hadn't done the follow-up that she didn't know about. Oy. Bray Patrick Lake, known to a lot of people working in health policy, multiple allergies, former police officer, implanted devices, treated at 5 systems, familiar story. None has her comprehensive record. Here's how that played out in December. She was involved in a horrible high-speed rear-end stoplight accident. And she declined ambulance transport and treatment to the closest hospital because she knew the consequences if she went to a hospital that didn't have her records. They might have harmed her. We can do better, folks, okay? Stacy, I can't pronounce her last name. Her Twitter name is Coffee Mommy. Usually she has this brilliant, bright, beaming smile. I had to dig into a video and get this screen capture with the appropriate expression for this. Look at this. She lived in Colorado. When she moved to California, her first mammogram diagnosed breast cancer. She tried to get the records from Colorado, including some previous breast issues. Feet were dragged, things didn't happen, and over time, eventually she was told, oh, we destroyed the records. How can the doctors in California treating her breast cancer possibly perform to the top of their training without that information that the people in Colorado destroyed? Remember Ross Martin back at the beginning? His wife Kim was hidden in that photo. Some years ago, she discovered that she had breast cancer, and the doctors needed information on her treatment for, I believe it was lymphoma, when she was a teenager, but those records had been destroyed. So the doctors in the current case had no way to optimize what would be the best, the most powerful potential treatment. So please, please. And here's Kristen Valdez. Her daughter nearly died of a contraindication. She has to repeat the story every time. And Stacy Hurt with a similar story. 3 patients she was assisting have died while Stacy was trying to pull together the records. Well, and just to come to the end of this part of the presentation, Betty McFalls, a 74-year-old lung cancer patient, she went to MD Anderson for expert treatment. Dr. FedEx, the printouts, they got lost. So there she is in Houston. They were gonna have to cancel the appointment, but hang on a couple of minutes. And then here is one, I've often said in my speeches, patient is not a third person word. Your time will come. And it's been a surprise to me as I've gotten involved in the FHIR community, how many people are in there partly because of their personal experience of, holy crap, can't we do better? Debbie Willis's father, who lived 12 hours away, fell. The hospital diagnosed him with a broken arm and sent him home to take Tylenol. The next day he was incoherent. They took him back. They said he was just in pain. On day 3, he was in a fetal position with pinpoint pupils. A nurse from the hospital visited. And what did she do? She called Debbie 3 states away, asking her if she knew if he'd had a head scan in the hospital. She looked in her app that she'd developed, which does what we anticipate this whole blooming ecosystem of apps will do. And she found from 3 states away that he hadn't. They took him to a different hospital that said, oh, he doesn't just have a broken arm, he's got a massive blood clot in his brain. It was too late for him, but pain meds let him die comfortably. We can do better, okay? Good can result when we do get to see these. Debbie's 91-year-old mother was placed on Benadryl for a rash. You're not supposed to put 91-year-olds on diphenhydramine. It's on the Beers list. She fell, she broke her arm. They put her on oxycodone, another thing you're not supposed to give to people that age. Sent her home, she fell again that night and hit her head. The ER doc checked her, but didn't take her off it. Debbie looked in her app, noticed what was going on, and called in and got things fixed. The patient with no medical training, just because she had access to the information. Remember Betty at MD Anderson? She was savvy enough. She brought copies of her data and images. And this is my mom, folks, and it gets personal to me. She had a new eye doctor. They wrongly charted her as diabetic, which led the doctor to wrongly order surgery. Fortunately, my mom's an e-patient, empowered and engaged. And when the doctor said, I'm going to order surgery, my mom said, why? And found out about the chart error. So it saved immense family stress, time and caregiving risk, needless expense. She caught it. And in a completely separate issue, when she was transferred to rehab, her caregiver daughters, my alpha sisters, as I call them, spotted a transcription error. Her thyroid condition was backwards and got it fixed. Because otherwise, you know what? The best doctor in the world would have done the wrong thing, looking at wrong information in the chart. we can say, look, all you doctors and nurses and everybody in the hospitals and clinics ought to be more careful. But I'm not in favor of making life more miserable for the professions that saved my life. My appeal is let patients help, and we can only do that if we can see the information. And yes, we need to take care of the nasty people like Facebook who are irresponsible with our data. But the remedy is not to say, hang on, patients. You know, paternalism is like when you've got a 2-year-old and you say, honey, no, don't touch the stove, you don't understand. I ain't no 2-year-old, you know? If people ought to be looking at the chart and they're not smart enough yet, the remedy is not to send them back to kindergarten, it's to help them get more competent by gaining experience. And Grace, on this call, rigorously checks to see that our anaphylactic morphine allergy is listed in every new chart. It often isn't. She wants a single record that's available everywhere. And finally, when Morgan, remember Morgan with the 23 charts, she is already able to advocate for herself at age 21. She went to college, changed hospitals. She brought along the protocol she had developed over years with her doctor. After she got meningitis, right? She showed it and worked with the new doctor who welcomed the engaged patient. She was able to advocate for herself and get the right treatments. This is the potential. My aim through all of this is to help healthcare achieve its potential with the citizen, patient, consumer, whatever you want to call us, as a competent, empowered partner. Access to patient data. There are more stories coming, folks. Makes a clinical difference. Real harm and benefit are happening now. Don't talk to me about bad things might happen, so we better keep it locked up. It's unconscious. Stories like that are happening every day. Let's fix it, okay? It's time to democratize healthcare. That's the title of this event, with patient-facing APIs, or as Grace puts it, it's time to humanize interop, to see the real life-changing things that happen. And because what I just showed you was a PowerPoint, which has limited life, I am now going to pop over and see if we go to Unblock Health. Don't talk to me about how many tabs I have open. Thank you very much. I'm well aware of that. Here is what Shahid and Grace have put together spur of the moment just in the last week. Okay, taking all of these and putting them online into what will be a growing collection of patient stories. So this is the beginning. This is version 1. It's entirely possible. It's very common when people see this presentation that they say, I have a story like that. And so wisely, Grace and Shahid, if you scroll up, put in a form to submit your own story. Of course, we'll vet them for spam, but and other kinds of tawdry internet experiences. These things are real. This is the patient's perspective. Why we've been working so hard for so long, saying, please give us our data. Grace, if I haven't already used up all our time, do you have anything you want to add?
No, I think you did a beautiful job. If there's any questions, we'd be happy to take them offline.
Yeah. Thanks, guys. No, ePatient Dave, as usual, beautiful stories. And so the only other thing I will add as a developer is, so, you know, as Grace and I, Dave and I talk quite a bit, these problems seem unsurmountable, but what Don Rucker just announced a little while ago make these more surmountable now. But what we're going to do with these patient stories on Unblock.Health specifically is that we want to take the stories, and these are complaints, right? Hey, give me my data, etc. But more than that, we want to actually give tools, technologies, processes, procedures, and actual solutions, so that with every story over the next few weeks and months, you're going to see this story could have easily been handled this way had the hospital had this step, this tool, this process in place. And so we've got to move beyond the idea of just complaining and say that we have to figure out how do we teach. And Dave said the beautiful words, which is, we don't want to make life for the providers who are saving our lives harder. So let's give them the solutions. that will give them the ability to help us help ourselves in these cases. With that,
Well,
I'd love to turn it over to Sunny, Andy, and Matthew Bolden to talk about leveraging the Google Healthcare APIs and in the cloud.
I just want to add, remember the second half of the presentation was cases where access to the information did save the day. So we're fully aligned.
Great, thanks guys. Go ahead, Sunny.
All right, I'm going to give it over to Matt Bolden.
All right, thank you, Sunny. Thank you so much, Shahid and Dave and Grace. That was very powerful and unfortunately relatable as well. My name is Matt Bolden, and I'm in the Health and Life Sciences division at Onyx, and I'm going to be the moderator here. So over the course of the afternoon, we've heard from some true leaders in health IT, from Dr. Rucker to David Lee to ePatient Dave and Dr. Cordovano, and we've all been talking about the need for access to information in an easy format for patients and providers to understand, as well as the impact that the new interoperability rules will have on these efforts. So we're going to continue on in that vein, but this time from the point of view of the technology creators and implementers. Feel free to add questions while Sunny and Andy are presenting, and I'll be keeping an eye on the Q&A for any of those questions. So with that, it's my pleasure to introduce Andy Crown and Sunny Southern to talk about how Google Cloud is addressing the needs of healthcare customers and created seamless tools to make data accessible in an appropriate way.
Thank you, Matthew. Can you hear me?
I can hear you just fine.
Okay, well, I think we're just going to do a very quick intro. So just picking up from, well, I've been at Google about a year now, and just picking up from what ePatient Dave said there, the reason I joined Google to lead the healthcare API is because I too believe we can do better, and I felt that the resources and capabilities that Google has would really allow us to do better for the community. So I've been in this healthcare and life sciences product space for years, but I'm delighted now to be in an organization that has incredible resources to apply to these kind of problems. Sunny, do you want to just introduce yourself?
Sure. Thanks, Andy. And it is really a pleasure to be here with everyone. I remember 10 years ago when the Meaningful Use Act passed, and there was the promise of being able to leverage health data once it was digitized. And as Adam Culbertson and I were talking a few days ago, really this new rule dropping is the biggest thing that's happened to us in 10 years. So we're thrilled to have the opportunity to speak with everyone today and to continue the great work that Google's done together to make data more accessible to healthcare providers and to patients around when needed.
Okay, so I think we're gonna whiz through some stuff pretty quickly here. Don Rucker at the beginning, he started by saying we've been trying to do interop for decades. I just wanted to read a couple of quotes here. This one, I need to bring attention to the urgent need to adopt some uniform publication system of the statistical records, and followed up by, if used smartly, these statistics will tell us the actual relative value of some current measures and forms of treatment. I would argue we've been trying to do this for way more than decades. That was actually said in 1863 by Florence Nightingale. So you could argue that actually this problem is over 150 years ago and old. And even then there was a desire for interoperability and sort of statistics that lead to actionable insights. One of the things that's kind of not really known about Florence Nightingale was she was known for her role as a nurse in the Crimean War. She was also a pioneer in statistics and visualization. So she developed this thing you're seeing here called the polar area diagram. And this was used to give the actionable insight that the significant cause of death for soldiers in that war was actually disease acquired in the hospitals after they were being treated for some sort of wound from the battle. And by process of elimination, they found that drainage and contaminated water was causing this. And so by making changes there, they were able to dramatically reduce the level of death. And so when we think about about sort of actionable insights, this is what we mean. And the other thing when you look at this that's interesting to me is this was produced with pen and paper, no computers 150 years ago. And you could be pessimistic and say, well, we haven't really moved that much forward. But actually, I think there's real optimism at this point for two reasons, really. First of all, I think we are getting to the world now where we have alignment of incentives, and I'll talk a little bit about that in a second, so that actually there's alignment for the stakeholders to want to make this change work. And the second is the emergence of the technical capabilities, so that folks have access to the skills and technology to make data interoperability work. So I want to dig into a couple of those for a second. In terms of incentives, I like to think of the carrot and stick continuum. So why would you make a change? Well, maybe there's a carrot to make the change, maybe there's a stick to make the change. And I've sort of drawn this continuum from the perspective of a provider, really. And on the stick side, some of the information sharing and blocking regulations we've heard about are really forcing functions. On the stick side as well, if you're a traditional player, we've heard about the app economy. Don Rucker talked about that as well. Healthcare will be disrupted by digital native entrants in the way that other industries are. That's going to be accelerated by information sharing. The payment models are changing. We're getting more towards the carrot now. That's actually good for some people, bad for others. Everyone wants better efficiencies and lower costs. And on the carrot side, I think once you get into a world of interoperable data, you also get into a world of potentially being able to derive new revenue streams, not from the data and selling the data, but from building insights and maybe machine learning models that could be monetized. So there's plenty of reasons, there's plenty of incentives that are going to drive the change. On the technical capabilities side, we at Google really firmly believe that standards are the mother of interoperability, and that FHIR in particular is going to drive that. And one of the reasons is because it addresses both sides of the interoperability challenge. So the functional challenge of sharing data and the semantic challenge of can you actually understand that data when you get it. And of course, when you get that data, we all want to do what Florence Nightingale wanted to do those years ago. We want to take that data and derive actionable insights out of that. But that actually requires quite a lot of technology components, and the barriers to entry there have been around access to computational power and analytics power. And this is really where Google can help apply its technology to help deliver on the challenge of can we do better and the future. So when I think about the future, one of the things that I like to do, we like to do here at Google is an exercise we call a postcard from the future. So you think about what will the future be 10 years from now, and you write yourself, the past version of yourself, a postcard with describing what that future looks like. And here are sort of 6 of the areas where we think really the world will look different in 10 years from now. We think the systems of record today, the EHRs, the back office systems, they'll still be there, and their evolution will still be slow. But what we think will be different is this concept of a secondary clinical data repository that is a common pattern that powers those applications and those analytics and AI models, and this will be FHIR based, and it will be near real time in sync with the systems of record. We do think API data interoperability will be ubiquitous. If you look at the financial services industry, it is there. If you look at other industries, APIs are over the tipping point. We think the regulatory stick will help, and we think this will be demanded by customers. We think that the world will, systems of engagement will have emerged. This app economy that Dr. Rucker talked about, smartphone-based chronic care management, these apps will be connected to the systems of record via the smart standards, and we think that digital natives will have a strong presence in the future. We firmly believe FHIR will be the global standard for representation and exchange of data, and it will be the index for data aggregation. that secondary clinical data repository will cover way more than just clinical data. It will cover patient-generated data, omics data, social determinants data, etc. We think that the managed service approach to APIs and analytics will dominate. There are stats out there that talk about what percentage of IT budget is used just to keep the lights on. That's really a wasteful approach. We think the ability to stand up API services in a managed way where you don't have to think about scalability and availability and reliability will dominate. And we think API surfaces will become as common as websites, and organizations will have to think about publishing their data through APIs in the way they think about publishing their annual report through their website. It's a different mindset. And lastly, we think that AI will have been proven to be the microscope of the future. So we think the really significant clinical discoveries over the next 10 years are likely to have come from pointing AI's capability at this data that has been normalized and is interoperable. And we don't think that that will happen in an on-premise world, because the compute power required to train those models and to run those models is too spiky. No one wants to pay for that infrastructure to be idle when you're not using it, and no one can afford to pay for the amount that you need when you do want to use it. We think branded ML models will be widely in use. We think organizations, provider institutions, life sciences companies will brand AI models that will be used in diagnostic and therapeutic purposes. So how do we help? Well, what we're trying to do is be a force multiplier that is driving the transformation to that future state vision. And we think that's driven by 4 vectors. We think interoperability is really key. We do believe that there'll be an ecosystem of these digital healthcare applications, and we want to drive the surfacing of insights, retrospective insights like the one Florence Nightingale built to look at death rates there through traditional analytical models, and that prospective predictions will be driven through AI. And so then the question becomes, well, what do we have to do to drive that transformation as a technology vendor? So there really are 3 areas that we are investing in. We are investing in a secure, scalable, and compliant infrastructure to run this on. We are investing in the interoperability and standards-based interoperability that makes data liquid, but in a safe and secure manner. And really, we're able to apply a lot of the Google capabilities in the AI and machine learning world to train models, but importantly, make those models explainable and integrated into the clinical experience, so that you can actually take some action on that insight, much like Florence Nightingale did. So this is a bit of an eye chart, I know, but what this is really giving you is a sense of what we have built in order to be able to power those solution builders that are going to transform the future. So if you work from the bottom up here, everything we've built runs in the cloud as a managed service API, meaning it scales up and down, and you just pay for what you need. You don't pay for what you don't need. At the bottom layer, everything we do runs on the same technical infrastructure that you see in the logos here. So you get scale out of the box here. This is the technical infrastructure that's powering, I think, 9 products now with over 1 billion users, because scalability is going to be a real issue and a hard one to plan for. The volume of data in the healthcare space dramatically increasing. On top of that, we have built a set of data governance services that allow that infrastructure to be stood up in a compliant manner, whatever the regulatory framework you have to comply to. HIPAA, high trust over here, but other frameworks around the world, and ensure that you don't drift out of compliance. And the bit that I own here is the data platform. That's the key to driving interoperability. This is the bit that provides the native ability to speak the standards of healthcare and interoperability. So what does that mean? That means you can stand up a FHIR server in minutes. You can have a FHIR server up and running in the sky in minutes. You can implement those US CDI profiles that Dr. Rucker talked about. You can implement the caring standards, the implementation guides that David Lee talked about. And you can use this as a back end to power those applications, to be sure that that sort of secondary clinical data repository running in the data platform has up-to-date data, so that as ePatient Dave talked about, the patients have access to their current data wherever they go in the palm of their hand. It's important to say at this point that this data is segregated and secure. So data that's put into the cloud, it can only be seen by the people who put it into the cloud. We as Google, we can't see that. We don't use that for training our algorithms over or serving ads. We're unable to do that. We secured and we can't even see it. So on top of that, then are the analytics and machine learning platforms that are really going to drive those insights. So we have a set of technology in the analytics space, tools that allow you to visualize data, but importantly, we're also preloading data sets that allow you to take a lot of the effort out of the data wrangling. So this could be ICD codes, it could be social determinants of health data, etc. And then obviously in Google, we're known for the ML platform, our ML capabilities. So we have an ML pipeline that plugs into this data that allows you to reach into that data platform, do your feature engineering, pull out the features that you want to train those models over, figure out the explainability of those models that the healthcare providers want to see, and then drive those inferences back into the clinical workflow. Now, the thing about this slide is that the things in blue are the things that we as Google are building and wrapping with our APIs. The things in black are the things that we expect the solution builders, whether they are customers or partners, to build to drive that transformation. And that's a good segue for me to hand over to Sunny, because Sunny is exactly one of those partners who's doing this kind of stuff. So I'm going to go over to you, Sunny. Do you want me to drive the slides?
Sure, if you don't mind.
When you want to advance.
Okay, well, hello, everybody. My name is Sunny Southern again, and I am the Vice President of Health and Life Sciences for ONC. And if you could go forward, Andy. So it probably is a little bit important to talk a little bit about our relationship of ONC with Google. We've been a Google partner since 2002, and we support the full Google stack. So I want to talk about that for just a second. When we talk about cloud, which is what we're talking about today in this part of the presentation, we mean both cloud solutions like G Suite and Chrome and the Maps platform, but also the cloud infrastructure that Andy talked about with all the amazing capabilities that it has. And so together, if you go to the next slide, Andy, with Google's amazing engineering and products that they create, we've helped hundreds of health and life sciences organizations leverage the power of these cloud solutions and infrastructure to do really amazing things. And I'm going to share more about some examples in just a second. So hundreds of these health and life sciences organizations are using the cloud to do interesting things. Andy, if you could go to the next slide. And these healthcare IT executives are choosing the cloud for several really key reasons. So on the left side, you see it's really about security and redundancy. Healthcare IT executives recognize that Google has a whole host of experts in the area of security and compliance. And so they create that infinitely scalable and secure infrastructure to run their applications and house their data. And then on the other side, where better to allow the data to be interoperable than in the cloud? And with some new products that Andy and his team are working on to help improve the interoperability, we're going to have even more capabilities around making it really easy for both developers and data scientists to leverage their data from wherever they are. Next slide, please. So one of the stories I want to talk to you about, unfortunately, I can't tell fun stories, as fun of stories as what Grace and Dave got to talk about from a patient perspective, but these are really exciting for us. So one of the first projects we want to talk about is a project that we're working on directly with Andy and his team to create a highly repeatable, scalable, and easy to use process for developers to leverage the healthcare API. One of the biggest challenges in testing new products is getting access to clinical data before the product has fully been tested. And so Google's partnered with MITRE Corporation, and we're supporting that initiative, to leverage a platform called Cynthia so that we can create what is realistic but not real synthetic data to be able to test these different solutions in the cloud. And so an example of a process that could be utilized by developers to test the healthcare API in their own applications. First, it's always important to define the use case, right? So defining the use case, do you want to identify patients at risk for diabetes and then be able to provide them with alerts and messages to help them remember to take their blood sugar, or to check their feet, or to drink more water on days that it's hot outside. So define your use case, and then use the MITRE Cynthia tool to generate that synthetic patient data. Then we can store that data really seamlessly in cloud storage on Google Cloud. We run a predefined Google Healthcare API FHIR operation in a predefined measurement point. So for example, from a testing perspective, let's say that you want to understand the performance up to about 100,000 patients. You might decide that you want to do increments of 10 to 50 to 75 to 100,000 just to make sure that your system is running the way that it should before you incorporate that live data. Once you've defined your predefined measurement points and then run your test, we store that data, the synthetic data, into the Google Healthcare API FHIR store, and then you can use it to do your analysis in the click of a button versus taking the time to have to spin this all up yourself. And one other note that I want to make that's not on the slide is the MITRE tool is fantastic. They've done a really great job in creating a strong methodology using demographic data and other realistic data at the county, or sorry, at the state level. But we are working with Google and MITRE to create a highly automated and scalable process to store that data on the Google Cloud Platform so you don't have to spin up your own VMs. On to the next story, please, if you wouldn't mind, Andy. Okay, so the next one's pretty simple, but it's really impactful because it's for community hospitals. So for those of you that don't live in a big city like New York or Chicago or Atlanta or San Francisco, but live in the middle of the country like this customer does, or where this customer has hospitals, margins are even more important in these community-based hospitals. And so finding a way to make a simple process for this hospital system to gather disparate data sets and make the information accessible and usable in a much quicker fashion was something that we were able to do here, just using simple Google tools. So in this particular use case, we were able to reduce manual steps of gathering the data from multiple different places from 50 to 5, and the time from 2 weeks to 1 day by using just simple Google tools. And in the future, what we are going to do is create a fully interactive report that's powered by the hopefully soon to be available Google Cloud Healthcare API. And for the very last story, for those of you that work in the health data space, many of us, including those of you that have either spoken or will speak, like Mark and Adam and others, the ability to leverage publicly available data combined with clinical data to help unearth population level insights are really critical. And we've had for years, for the last 8 or 10 years, we've had public data sets available, but the challenges related to normalizing that data, marrying it with other data, having it be able to be stored in a place that other people could access has been incredibly challenging. So in this particular use case, we talk about a project that we did for an academic institution with actually 40 data scientists that work for NASA to combine some newly available synthetic satellite data around air pollution with, once again, you're seeing it, that Cynthia data, to be able to unearth insights related to hospitalizations and pollution. And if you could go to the next slide, you can show the visualization. So we were able, again, with some just very simple tools and just a few hours work to take these disparate data sets, analyze them using GIS data, and then marry them together so that you could see the relationship between hospitalizations for acute bronchitis and viral sinusitis and pollution. Next slide, please. Okay, so we've talked about the API and what Google's doing in this space. We've talked about the cloud and some very specific examples of how healthcare IT executives are interested and comfortable with using the cloud, and how health systems are actually using the cloud to make meaningful change within their organizations. And as you can see, and we all agree, I think, is that really we've got to continue to make this data interoperable for our health systems so that they can get better insights and we can improve outcomes and reduce costs. And for this audience specifically, so that patients can get access to their own blank data so that they can make the most informed decisions for themselves. And that's all we have today. Thank you all so much. I think we can take a few questions if anybody's interested in hearing more.
Thank you so much, Andy and Sunny. And looks like Andy and Sunny, could you go on mute? Thank you. Looks like we do have a few questions. So to start with Virginia's question, how do you see, this is for Andy, how do you see clinical workflow and clinician IT interaction changing in your future postcard?
Sorry, could you repeat that? I was just trying to stop the sharing. I didn't quite catch that.
Okay, no worries. How do you see clinical workflow and clinician IT interaction changing in your future postcard?
So I think there's a sort of technology answer to that, and then there's a sort of a workflow answer to that. So perhaps best with an example, actually. So what we're able to do with this kind of technology, for example, is build a model that can give a probability score that a patient will develop sepsis during an inpatient stay. So you're able to integrate that into the clinical workflow through tools such as CDS Hook, so that you can trap the event upon the admission of a patient to a provider system. You can take that event, kick the ML model, come back with a probability score, give that back to the person who is admitting the patient in real time, and then you can make a different decision about the care pathway that you want that patient to work on. So it's a combination, I think, of the maturing of the technologies that allow this sort of loose coupling of the old systems of record with the new systems of engagement, but also the ability to develop those models that have add value into that workflow. So both of those things are kind of happening simultaneously, and we're starting to see examples of where they're being applied today. So by the time we cast our mind forward to the future, I think that will be commonplace.
Okay. So I think that dovetails really well with Adam's question, actually, talking about the models that are available. He asks, there are many functions available with Google Cloud, some of which you've just alluded to, and Sunny, feel free to chime in here as well. But how can someone get started on Google Cloud to take advantage of these capabilities and these functions?
Okay, well, let me take a stab at that, then I can pass over to Sunny. So I think it really depends on your level of knowledge going in. So assuming that that you're wanting to essentially build something yourself, then there are lots of if you search for Google Cloud Healthcare API, there's a lot of documentation there. There's a lot of quick labs and tutorials. So you can have a hands-on experience with the API and start to use it without having to spend any money on Google Cloud. You can basically, the quick labs spin up an environment you can work in. Now, on the other hand, if you're wanting to get the value, but you're not really have the desire or capability to be a developer, that's where we would say work with one of our partners who can bring that capability. And so, Sunny, I don't know whether you want to talk about how that engagement might look.
Yeah, sure, I'd be happy to. So really, it works pretty simply. I mean, somebody reaches out to us and we help to define what their challenges are, understand the requirements, and then help them choose the tools that are best for them. And we do that either through traditional professional services engagements. We also offer more hands-on workshops. And we're also very happy if somebody has a question they want to understand more about, especially the healthcare API, you're welcome to just call us up. And we love talking about this stuff. Our engineers love to talk about the work that they do. And I'm also going to post the Quick Labs link in the chat here. So maybe that can be shared other places so that if people want to look at things themselves, they have a place to go.
Oh, thank you.
Perfect. Okay, another question for you, Andy. You mentioned a secondary clinical data repository on your postcards from the future slide. You mentioned again later talking about how APIs interact with the infrastructure. Can you tell us more about what this looks like, these secondary clinical data repositories?
Yeah, sure. So this is really, we see one of two patterns at the moment. We see, if you're a digital native and you don't have these systems of record already, then we see people building on top of FHIR directly applications for things like diabetes management. But if you're more of a traditional healthcare organization where you maybe have 10 different EHRs. You maybe have a lot of data that you decommission from your old EHRs. You may have lots of different systems. And that infrastructure was not really built to serve applications or serve analytics or machine learning pipelines. So the pattern that we see is people building a secondary data layer, secondary clinical data repository, which is essentially hydrated from that historic data you may have, which could be sort of CSV format, could be listening into HL7 feeds and doing a transformation from those formats into FHIR, and essentially then deduping and linking in other sources of data, such as imaging data, DICOM streams, or patient-generated data, such that the FHIR representation is a longitudinal view of everything that you know about that patient, and you can use to drive the applications and the AI models. So, and it's near real time essentially, because it's listening into the changes that are happening on the systems of record. So think of it as the engine first, the systems of engagement.
Sure. Okay. And so both of you mentioned the Google Cloud Healthcare API. I was wondering if you could talk to us just a little bit about what that's going to look like in terms of its capabilities, its function.
Well, absolutely. So the first thing that's kind of exciting about that is we are just about to go GA with that. I can't kind of announce the actual date, but it's very soon, which will be great. And you can, the best way to really get smarter about it is to go online and look at if you Google Google Cloud Healthcare API, you can see all the documentation. It's up there. But essentially, think of it as a set of managed APIs that allow you to implement the standards that we've been talking about. So if you want to use FHIR, it is an implementation of the FHIR standard, along with some other value-add capabilities that aren't in the FHIR standard, things like the ability to do DID over it, to run, to pull out PHI data, single API calls that allow you to push that data into a sort of a SQL representation in BigQuery that you can run the kind of dashboard that or visualization that Sunny showed. And then we have the same for DICOM, we have the same for HL7, and essentially it's a super simple managed service set of APIs that give you a REST interface to work with if you're a developer.
Okay, all right. I'm going to wrap up with one more question here. Sunny, this one's for you. So you mentioned a statistic in your presentation. You talked about how 84% of healthcare executives are turning to the cloud to store sensitive information. I was wondering if you could talk to us about what it is about the cloud, what the reasons are for healthcare increasingly turning to the cloud.
Sure, happy to. So, what we're hearing more and more from both healthcare provider executives, as well as with health IT vendors like Meditech that we've done quite a bit with this week over the timeframe for HIMSS in the virtual world. And they want to get out of the data center business. They want to be able to spend more of their engineering talent and resources on doing the work that their company was designed to do. So a healthcare IT executive in a hospital system wants to spend the resources taking care of patients, deriving insights from their data, and less time managing, the heating and cooling of the server room and worrying about hardware refreshes and downtimes and all of that, and let Google take care of it, and then focus their resources on the things that really matter to their business, and let the experts in the cloud take care of the rest.
Sure, makes sense. Is there anything else either of you two would like to share?
No, thanks. Thanks for everyone's attention.
Perfect. All right, well,
Yeah.
thank you both.
Thanks
So
for
go ahead.
making this possible. It really, it's an honor to be part of this particular initiative, talking about such a critical thing as information blocking. And I'm really looking forward to hopefully this being just the beginning of a whole lot of new opportunities for all of us to help healthcare providers and patients make more informed decisions about their health.
Perfect. All right, well, thank you both so much. With that, I'm going to turn it back over to Adam and Megan.
Thanks. So I got the privilege of introducing Graham Grieve, the man who really started it all. He's joining us from down under in Australia. Graham?
Hey, Adam, how are you? Nice to be
Doing
here.
well. Are you hidden in your coronavirus bunker in Australia?
Certainly am. Things are warming up here, so looking forward to the next couple of weeks. Not.
Very nice.
Well, let's see if I make the light a bit better. I don't know, I think that's actually any better. I don't know why it's so red. It doesn't feel red here. Sorry.
Fair enough. Yeah. Do you want to share a little bit more of how FHIR came to be, how the ideas came, and how it was really came to being, and then also share some thoughts of what these rules mean and where you see things going?
Sure. Do you want me to make a presentation or just we'll chat? Which do you want to? Which are we doing?
If you have a quick presentation format, or we could have more of a chat.
Okay, we'll sit with a chat then. So I started working on FHIR in 2010. So 2011. So 8-9 years ago now. It came out of my dissatisfaction with where healthcare was, where the standards were, where our business and clinical models were. Healthcare's as IT products are old and not keeping up with the times, the standards weren't enough to be keeping up, and healthcare is deeply broken. I engage with the healthcare system now all around the world, but then not so much. But what I see is a system where everybody's focused on making their own bit run as well as they can, and where everybody's interested or responsible for the outcomes of their own bit. And so there's all these little bits all over the place that don't build a coherent whole. And speaking as a patient, thing that and that other patients encounter is the different parts of the system are working differently. It's just seeking different outcomes. And so here's a typical story. My mother-in-law, she goes to see a GP. He refers her to a specialist. The specialist says, hey, we're going to do this, put you on this medication. She goes back to the GP and the GP says, yeah, you shouldn't take that medication. Don't do that. And she goes back to the specialist and the specialist says, well, why do you come see me if you're not going to do what I say? That's a common story around the world and particularly acute for mental health patients. How's a patient supposed to resolve that? We can do better than that. We can give people better outcomes more effectively if we coordinate better. But in order to do that, we need better IT. IT is not the only problem here. There is a lot of other problems, but we won't solve it without better IT. And so because of that, you know, I said we can take on the IT problem and build better IT APIs that allow better integration of healthcare data. And that is, that was the genesis of FHIR. So since then, we set out and said, well, we're building your API, and a few people jumped on board immediately and said, this is our future, this is what we need. And so we started working on it. And over the last 8 years, we've gradually built a community of thousands of people help us build and specify the APIs that, you know, the future of healthcare will be built on. And I'm just really amazed that I've ended up leading that community, and that the community's got so much passion and power, and that we've started leading to outcomes like, you know, the rules that have just been released specifying that systems need to make a visible public API using the community-based specifications. I just think that's an amazing enabler from a technology point of view, and I'm looking forward to, over the next few years, hearing of amazing healthcare outcomes that people have been able to build on proper APIs that make information available and that let people create workflows and services that make a difference in people's lives.
So what do you think the biggest barrier to meeting the rules will be? Do you think it will be challenging? Do you think it will be easy for developers?
So I think that people come and tell me about their challenges. I think the biggest challenge that's not just a matter of execution is that it still will be that the different vendors and different institutions will have different behavior of the API. You know, we can test and do conformance, and I hope that we do that effectively. But no matter how much conformance testing we do, the APIs will behave differently. And it's an iterative process to drive out those differences. There will be differences around application registration, around token management, around the on-ramp process. And the rules, there's certainly areas in that variation that the rules don't address. And so it'll be interesting to see how much inconsistency developers struggle with. It'll still be less than we have, a lot less than we have now. So I don't want to be critical there. Getting a community interop to be consistent is an iterative process. Well, I think a deeper challenge is that even when the API surfaces are consistent, the information that flows through them is still hyper variable between institutions. As long as institutions spend hundreds of millions of dollars adapting the EHR products to themselves, that's going to be hundreds of millions of dollars worth of differences in behavior across different institutions. And I think that increasingly, like, it's a generational thing. In 5 to 10 years' time, people will be saying, great, we have all this amazing access to data, but man, it's really hard to do anything when institutions behave so differently between themselves. That's the whole area of standardization of medicine that, say, Atul Gawande has been talking about for years, around standardizing clinical practices where it's just not beneficial to have variance. But that's a whole different community and a whole different kind of regulatory levers and a whole different process. More and more, the people who can drive that process, clinical standards setters rather than IT standard setters, are starting to get involved in the FHIR community. and there's a whole bunch of projects coming into the FHIR community this year that will start addressing some of those issues. But it's going to be a long path to get people's institutions' heads around starting to change the way they do business in order to enable wider skill. So, you know, what I usually say when I speak is we build communities and we build information management specifications, but the real challenges that we're moving to now are clinical management challenges. And that's where all the action's going to be in the future to try and, you know, really leverage the healthcare system that we imagine that we can build.
Very nice. I think, yeah, I mean, there's certainly a lot of work to be done, but I think you've, really laid out a path for the community to, follow forward.
Yeah, well, thank you. I'm just really lucky to have such an amazing, passionate, well-connected community. But I do want to speak a little bit about that. We said from the beginning, FHIR's open. It's open source, it's open community. And the community that we've built, which is the real value proposition that we have, is building public treasure. So it's just a weird thing, because people come to us and they give us their treasure and we hold it and make it available to everybody. And then nobody owns it because everybody owns it, but everybody is richer because everybody owns it. If a company said, well, this is our stuff, this is our API, then people would go, well, how can I build to that? And then they couldn't build a platform that people would commit to because everything about it would be proprietary. So in fact, companies are better off because they can build solutions that where the engagement path is not proprietary and their value is deeper in the functionality they provide. And so what that means is everybody's richer, and like consumers or governments, everybody's better off because everybody owns what we're doing. It's a really unusual property of public information management solutions. So public treasure, and our business is to build that. And so what I always say to people is I encourage everybody to spend a little bit of their time every week, a few hours every week, committing to build public treasure somewhere. You can join us, and we love it when people join us, but join something, a professional society or a local, civic value builder or some other derived community from FHIR, and commit to building something that's bigger than you, that's public treasure that we all benefit from. And there is such a huge need for that across all the healthcare system.
Yeah, I think that's great advice, and thanks for joining us all the way from Australia, and for all the great work that you've done. And so I'm going to turn it over to, I believe, let me check here. Matthew is going to talk a little bit more about the uptake of FHIR. Matthew?
Here I come. Morning, evening, nighttime, Graham. Thanks for staying up. You can go back to bed now.
Hey, Matthew. No, I got up this morning early.
It's early. All right, fantastic. Okay, well, I will dump you off the video, and I will take over for now.
Right, thank you.
I'm going to be really brief, and I actually wouldn't mind you and Adam staying around for the very end of my. I'm going to try and get. I've got 15 minutes. I'm going to try and get it done in about 6 or 7, and because I have some data, but it's kind of old data. So let's dive into that. So here's what happened. About 5 years ago, the California Healthcare Foundation came to me and said, we've heard about all these small tech companies having trouble getting access to the APIs and the data and working with the big EMR vendors. So in 2016, I did a survey working with Kim Kruger at Health 2.0 of really what was going on. In 2018, I updated that survey, did it again. And as you heard, those of you who are on right at the start, it looks like ONC is going to do not this exact survey, but a variant of this survey looking at the progress of FHIR sometime this year. And Catalyst Health 2.0, which is what the old Health 2.0 is now called, is going to be working on that topic as well. So hopefully it'll be like a 2020 update to this 2018 data. So bear in mind, this data is by definition now 2 years old, and a lot of stuff's changed. I will be asking Graham and others and Adam to contribute about that. But let's run you through what happened. So first up, what actually was this survey of? This survey was of of technology vendors who were working, in general, small companies who were working to try to get access to data on the big EMR vendor players. This is US based, but the main vendors they were working with, obviously, with the Epics, the Cernas, the Athenas, the Allscripts. You'll see their data come up. And we asked them to name names about things like API quality and what they were using and what they were doing. So I'm just going to give you a very brief rundown. Bear in mind again. So we got 2 good answers from only about 100 vendors in the end. So it was a really hard work getting people to answer this survey. And there's a lot of, I think, lack of certainty and lack of clarity about what actually was going on in the world. But nonetheless, I would say the overview was true. It was definitely tough. The overview that we got from the California Healthcare Foundation came to us with was true. It was definitely in 2016 tough to get access to APIs, to get access to data, to work with these big vendors if you're a small tech vendor. And hopefully the regulations that Don Rucker talked about early on this morning or this afternoon will hopefully start changing that. So let me just run through the data real quick as to what happened, and then perhaps we can have a quick discussion about how things have progressed. So this was a 2018 question saying how was a sort of sentiment question, which is how much have the mainstream EL vendors made it easier to access API or get to access to data for you as a small tech vendor trying to do something with them? And about in 2018 over 2016, in the last couple of years, a quarter of vendors said a significant improvement, and about nearly 2/3 said there'd been a modest improvement. So things are definitely getting better from the mainstream EMR vendors. Next question we asked is, how much difference do you think the providers, the actual hospital systems, who are the ones working with the vendors, how much have they made it easier? And again, a decent chunk of the vendors we talked to said they were making it better, but not quite as many thought there'd been a modest improvement as had with the vendors. So in some ways, the vendors perhaps were doing a little bit better than the providers who they were working for. So then I asked a bunch of other questions, more technical ones, like how were you getting access to that data? So if you're working with if you're a small tech company providing some function, whether it's a tool for physicians or a data extraction tool for consumers, or one of those different things, taking advantage of the data that's in those EMRs, how did you access the data? And the answer was pretty much that a couple of the vendors, Athena Health and Allscripts, who had made significant efforts, actually did enable that data access pretty routinely via their API. That's the blue area here. You can see it's much stronger for Allscripts and Athena. Most of the rest of them were using a third-party data integration engine. That's the orange one. Or we're using some kind of batch or using direct or some other type of protocol. And some vendors were sort of far behind on the API front, particularly NextGen and Meditech. Probably not a significant surprise to those of you who've been working in the field. Then I looked at the difference between 2016 and 2018, 2018 on the left here and 2016, as to how people got in. And it was, Athena Health had bulked up their API a little bit and had a few more people coming to their API. Epic and Cerner were remarkably similar, a little bit of a bump, but you'll notice there was a pretty big bump here in this orange category of third-party integration engine. And I call this the Redox effect. People like Redox, Datica, some of those other companies enabling easier access, going to them and using their integration to the Epic and Cerner APIs rather than doing it direct. There were some other issues that came up, and these, so particularly, here's one which was, were there any terms in contracting with the client or vendor that you found troubling? You know, in other words, if you're working with a vendor, did they ask access to your tools? If you're working with that, with an App Exchange, AppGon, App Orchard, one of those things, was there any problems? And about 40% of companies said that there was a lot of problems that they didn't like, you know, regarding that. So it wasn't this idea to get to an API App Store, App Exchange, because it was a significant trouble back then. And actually, a little bit after the survey was done, Epic actually changed its terms for App Orchard, which had been called out as having problematic terms and onerous terms. Then I asked a bigger question, which was, okay, if you worked with an EMR vendor, for the whole integration process, do they help or do they hinder? And in general, so red here is hindered and green is helped. So you can see that in general, it was regarded that, these are small numbers, but you get the flavor, that Cerner was about neutral. Epic was more on the hindering side. eClinicalWorks and Meditech more on the hindering side. Again, Allscripts and Athena Health, who have made a lot of effort in those days to build partnership programs, were regarded as much more helpful than everyone else. Same thing is true around sort of overall partner programs. You know, was there a partner program that you could slot into? And again, the same thing is basically true. If you look over here, the blue is, yes, it was a good program, it was easy to understand, worked well for Allscripts and Athena. Pretty much Cerner was kind of getting there. And then the orange is, yeah, it was a program that existed, it was a little bit complicated. You know, you can see the more orange. Epic somewhere in the middle there. Cerner was kind of getting there as well, having an easy program. Allscripts and Athena had put a lot of effort into their programs. It was clear in the data that came true. Those others hadn't. Some like NextGen and eClinicalWorks were very tough to work with. Now, I mean, I pulled a couple of quotes. There's a lot of data if you go to the study, and I'll show you how to get to this study in the end. But basically saying that some people are good, some people are not, and some people are unreasonable. No prize for guessing who the big kahuna is who was regarded as being unreasonable back in 2018. And you know, this probably wouldn't surprise those of you who've seen the reaction of Epic to the upcoming rules that have just now been issued compared to what Cerner said. And I think there's a lot of questions about, again, these big vendors and how they're playing. And I feel there'll be some change. All right, the app stores are getting real though. This is 2 years ago, and for app stores that were relatively new at the time, even Athena Health and Allscripts and Cerner, yeah, they were just there were people who were starting to get involved, and these numbers I'm sure would have gone up in the last couple of years. All right. Then there's a question I put in about providers. So bear in mind that, and this is a question that Anish Chopra actually asked me to put in, a lot of them had already had, a lot of the vendors had opened their FHIR standards, but not many providers at that point have made them available. Now, since and around the time I was asking this question, and since then, Apple has done a lot of work to open up, access to data. You can now get direct on Apple Health records, the old Glimpse that they bought. But in general, most of the people, only 13% of the vendors, again, these are small tech vendors who are presumably trying to work directly with these providers, only 13% of them said that they had provider clients who already made that data available via FHIR, and only another 22% said it was going to come. And the rest of it found there was little interest or just didn't know about it, or just there was no work with it. So again, providers may be a big hurdle. Interesting to see how providers have changed over the last couple of years, especially how they will change with the new regulations. And here's the last slide. And I think it sums up, I just took some quotes here. I just asked a bunch of open-ended questions about what was going on in this world. And in general, there are a lot of problems. One is that, I think as Graham just mentioned, APIs are not just APIs. There's lots of problems with APIs. Troubleshooting them, working with them is very hard. A lot of issues around getting access to, say, Epic's EMR, integrating with that, whether it's Epic or other big EMRs. A lot of people talk about it being a nightmare. And the final one, which I think was sort of backed up by what we found in the survey, was that Athena, aside, and maybe Allscripts, the EMR vendors are not open despite all that activity they project with their involvement in things like Argonaut and FHIR. So again, a couple of things. This data is 2 years old. Since this data was taken, Athena Health itself got merged with the whatever the hell the legacy GE system was called, and got taken private. And I haven't really talked to them about, they've had big changes. I haven't really talked to them aggressively about how they're partnership program is going, and be interested to know if anyone has any insight into that. And of course, we've had the regulation. The regulation was proposed a year ago, finalized just in the last week, and we're going to see, you know, there is much more pressure now on both EMR vendors and providers to actually open up that data and use the FHIR standards, and lot clearer guidelines, as we heard, not just from Graham, but also from Don Rucker this morning. So last thing I'm going to share with you is, I'm going to stop sharing this and share something else, is just to show you where this data is. You can find it in this post on the healthcare blog, which is called EMRs, APIs, app stores, and all that more data. It's a write-up of what I kind of just what I said. There's a lot more data here than I showed you. There's 55 slides. I just showed you 12. So you got the idea. So a lot more data here. As I said, I'm not entirely certain what the ONC survey that's going to come up on FHIR is going to look at and how much of these questions are going to be repeated. I don't actually have plans to repeat this particular survey, although maybe I should, depending on how that other survey goes. It is honestly a real pain in the ass surveying small tech vendors. It took a lot of effort, a lot of time to get even 100 plus responses. But the people I surveyed were the people right at the coalface of integrating and figuring out what was happening with these EMR vendors. So at that point, I will shut up, and I would love just maybe my question to some of the people on, and maybe Adam and Graham, if you're still awake, you can come back. Is maybe Shahid as well has some opinions, or maybe other people following this. I'm not looking at the. Actually, I can go over and look at the YouTube screen. I don't see any questions for me there. But are there any other questions regarding? My question is, what if we did the survey again today without actually knowing the answer? Shahid, I can answer you this, and maybe ask Adam as well. Would I've seen, with the rules coming, would you have seen a lot more change? We've seen a lot more openness and a lot more ease in order to build applications on top of the data that's in those EMRs. We've seen companies like Innovasa and some others sort of build sort of new longitudinal records across multiple systems. You're seeing a lot of venture capital go into that. Hundreds of millions of dollars gone to them and some others. Will this all change, or are we kind of still inching along? So I leave that as my question to you, because I don't work in this every day. It's an interesting topic that someone came and talked to us about, but I probably am not at the coalface the way you guys. So I'd love to hear your response to that.
Sure. Yeah, I think from a pure developer perspective, this is all very, very real now to everyone. So when I talk to the way that you actually understand what's going on in the industry is you don't really talk as much to just developers, but their product managers as well. So when you look at the product managers and the roadmaps, those are the two things that tell us whether or not things are real or things are fake. So as I talk to product managers, it is now on their roadmaps to do these currently just point-to-point APIs. What we're not seeing is a wide conformance testing to multiple point APIs. So for example, through gateways and other things. But the simple answer to your question is, I think if you were to run the survey again, which I would certainly suggest that we run it very regularly, is that it's very real. The product, the roadmaps have them as planning going on. And especially with things like Smart on FHIR, which Adam and team will talk about in a bit, it's very real. So I think the good news for patients especially is that what Apple has done and what our friends on the Android community are going to be doing as a kind of like another version of HealthKit for Android, those are showing, those are probably the things that moved it the most. It's not even all the rules and regulations and everything else. It was just Apple saying, if you don't have FHIR enabled, you do not show up on the HealthKit list of hospitals. That's what actually moved everything. So if we can push more from the consumer end there on the Apple side, I think we'll see a lot more faster, I should say, not just more, but faster uptake on all this stuff.
Adam, you have a comment? Adam, get off mute.
I'm on mute. So curious to hear Graham's thoughts on this, but I mean, for me, I think it'd be interesting to see, which version of FHIR folks are using. So I predict since R4 is now mandated, you'll see, people who haven't started will jump obviously onto R4. And so you'll see kind of a big, R2, R3 will have, less adoption. And then of course, you'll see a big explosion around R4. And then, of course, you still will always have some proprietary APIs, but it'll be interesting to see what the mix is.
It's hard for me to comment because I work with the developers, a long way ahead of the curve, and then I hear feedback driven by market input, which we feed back into the start of the process. But I think that I'd answer that the situation somewhere between what you presented as choices, Matthew, that there is progress. It's incremental, it's not radical, but it's not inching. It's a little bit better than that. Of course, there's always, like it's a glass half full or empty, but people are iterating over time on consistency. The health kit process is driving consistency. We feedback stuff to the developers, and they cycle improvements. Then we feedback stuff to the regulations, and they drive improvements. There's no magic bullet. There's never going to be a magic bullet. All there is people with their heads down, incrementally improving things. And so it's not as big as it could be, but I think it's not as bad as you fear.
Yeah, look, I think there is genuine, to my mind, and we've had this, with the fuss about the letter from Epic and trying to get their hospitals, which in the end, not that many of the big systems signed. And Cerner took a very different approach to this. So it's interesting to see that in industry. But the idea about, where are the big players? Because the answer is in the US particularly, and also elsewhere, you've had massive consolidation of hospital systems. They're generally consolidating around one of those big EMR vendors. In some cases, they have to have multiple EMR systems across the hospital provider organization. They have to somehow integrate them internally. But in general, they're all, you get something like an Atrium going just, which used to be a bunch of different systems going to Epic, etc. And there is a lot of power in what those vendors allow and what the providers ask for them. And that is going to be the place we're going to this is going to play out over the next several years. That's no question in the US, and increasingly as those EMR vendors go abroad, in multiple other countries. Having said that, there is a ton of data that's useful to the healthcare system coming from all kinds of other places, and we had the folks from Google and elsewhere. They're buying Fitbit. You've got innumerable sort of patient outcomes data and other people with data sources. And you're right, someone has to bring this all together in a sensible way that's useful for patients and clinicians. And my hope is that we kind of, in spirit of what you just said, Graham, have all the people going towards what's a common goal. Because in the end, and in fact, we're seeing right now with COVID-19, the coronavirus, that we need to have better information about everything, because healthcare is a social good, and maybe America is just waking up to that. But for God's sake, Italy knows, All right, so I've said a lot. Adam, it's you're up next, I believe. I'll go away.
All right, thanks, Matthew, and thanks, Graham.
You can go back to bed, Graham. Good night. Good morning.
Thanks very much.
Let's see. Just trying to figure out how to share my slides. I think there's a...
It's
the green button down the bottom.
Oh, there we go. Desktop one. All right. Can you see my slides?
Yep.
I can see them.
Okay, great. So my name is Adam Culbertson. My day job, I'm a senior manager of technology innovation at CAQH Core. So make sure I give a shout out there. And then in my spare time, I still get to work with the SMART team as the SMART evangelist.
Adam, sorry to interrupt. So we're seeing your preview screen. So if you click the button that says swap displays up there, we'll see the full screen.
Okay, let me
see where it says swap displays.
Oh, let me, sorry about that. Share. All right, can you see, am I on now?
Yeah, now you just need to go to slideshow mode.
Yep. All right.
And now you see where it says swap displays up in the top left corner?
There we go. Sorry. There we go.
Hey, now you're all set. Go for it.
Yeah. Sorry about that. It's always fun trying to manage dual monitors here. So yeah, so this is a brief intro to SMART. So basically SMART is a platform. So it's built on top of leverages the FHIR API, and it's a standards-based tech stack. It has open source tools and resources, industry support, and a public app gallery. So this work was first described by Josh Mendel and with SMART on FHIR, standards-based interoperable apps platform with Ken Mandel's group. And it was funded through an ONC grant that got this work initially started. So it's a standards-based technology. And so the SMART standard leverages OAuth, OpenID Connect, the FHIR API, as well as the SMART Argonaut profiles. So the idea behind SMART is you can build substitutable apps, right? So it's a standards-based platform that enables innovators to create apps that's seamlessly and securely run across the healthcare system. And the whole idea, right, of nothing else, right? SMART is about building once and deploying multiple times. Rick's going to talk a little bit later about some of the challenges of doing this, but ideally we want to get as close to this paradigm where we build one app and we can build it across, deploy it across multiple paradigms. You know, so SMART, as I mentioned, has been around for a while. So it started in 2009. And of course, you know, a little more than a decade later, we have these proposed rules that actually will require the development of some SMART applications. So Mark Scrimshire will talk about Blue Button. But basically, it's, you know, the idea of you build once, deploy multiple times. Apple has used the technology on the version 2 to roll out an app on the smartphone. SMART includes an app gallery. So one common app's the bilirubin chart. Folks who have followed this space should be really familiar with many of these apps. But if you're new to the space and just tuning in, these are just a few example apps that have been built and are listed in the SMART app gallery. SMART also has CDS hooks. And so the idea behind CDS hooks is you can leverage a third-party knowledge base and integrate it into the EHR within the clinical workflow. And then also bulk data. I'm not going to go into those because we don't really have time today, but just want to mention them. And then also tools and resources. So here's some main resources. I would encourage folks to go to the smarthealthit.org and explore all the different resources that are available. So there's SMART developer resources, a SMART sandbox. There's version 2, 3, and 4 that you can play with. There's code libraries and of course bulk data reference server. There's also a bulk data testing server that folks can work with and use. So I know that was quick, but I'm going to turn it over to Rick to share how you can sort of move towards this vision of build once and deploy multiple times.
All right, thanks, Adam. Can everyone see my screen and hear me okay?
Yep.
Yes.
Awesome. Okay, well, first of all, I'm excited to be here. It's exciting to see how we're adapting to this new age and moving on to YouTube and away from face-to-face. And I personally was really excited to talk about something that I've been passionate about and been involved with for a number of years. And so today, in the 5 to 7 minutes that I have, I'm going to try and go pretty quickly through some of the things that we've helped create and that it exists in the community to help drive adoption for SMART on FHIR. And then I want to finish off by talking about some of the challenges and pitfalls that are out there in the marketplace now. We'll be there for a little bit, but ways that we can adapt to overcome them and really make the SMART on FHIR and CDS hooks-based ecosystem a real success. So first thing about us is if you haven't heard of Interopian before,
We actually were the ones that created some of the original Smart on FHIR applications, some of the greatest hits that now they've been out there for a while. Hopefully many of you have had a chance to see them. We also are the creator of the HSPC Sandbox, and the HSPC recently rebranded to Logica Health, and so now it's called the Logica Sandbox. And it would be, I'd be remiss if I didn't talk about the generous funding from Intermountain Healthcare, both in funding the development of the Logica Health Sandbox, but also in the time that their talented informaticists and team have put to help us work through creating something that works well for our healthcare systems and for people who are building applications that will eventually go into a clinical setting. I'm going to talk more about the sandbox here in a second, but first I want to talk to you about the Logica Developer Program. And like I said, Logica used to be HSPC, and so everything's in the process of being rebranded now. So you'll probably see HSPC on a few of these artifacts still. And that's just because we haven't had a chance to get the websites updated. But whenever you see that, they're all moving towards Logica. So the Logica Developer Program really breaks down into three major categories. One, we have a developer portal. And the purpose of the developer portal is to give you and your team or developers the tools that they need to jumpstart creating Smart on FHIR applications. There's a sandbox that I'm going to talk about in a little more detail now in a few seconds, as well as a gallery that once you have your application built and you feel like it's now ready to start showing off and having people drumming up interest, we have a gallery as well. So first, the Logica Developer Portal. There are a series of SDKs and libraries that have been developed by the community. Some of it by the Logica developer team, some of it in conjunction with the SMART team, some of them by the SMART team, some of them by other organizations. But the exciting thing is that a large developer community has come together to build a set of open source standards and open source SDKs and libraries that will really help organizations take existing applications, existing decision support modules, and make them Smart on FHIR capable or CDS hooks capable pretty rapidly. There's also a series of samples and tutorials to help work through getting started and understanding what it is and how it works, as well as some additional documentation. And that's found at developers.hspconsortium.org today. Soon it will be developers.logica.org, logicahealth.org, but don't worry, the redirect will work when that change happens here in the near future. So the sandbox. If we had a little more time, I would have spent some time actually showing you the sandbox. That's when it really shines, when we have an opportunity to show you how quickly you can spin up your very own cloud-based instance of a Smart on FHIR platform, to fill it full of data, and then register applications and start using those applications and building scenarios of how your application should be or could be used in production. So like I mentioned already, the number one benefit I think about the Logica Sandbox is that you can, in a few clicks, get this thing stood up and running. You can pick which version of FHIR that you would like to build your application against. We support all the major versions as well as incremental versions. So it's a big importance to Logica, Intermountain, and Interopian that we support the movement forward on the next versions of FHIR. So as new versions are released, we try to uptake those and make them available so that people can start testing those at connectathons and so on and so forth. The Logica Sandbox, this is one of those things where it's better seen than talked about, but we have support for now we have support for CDS hooks. We have an EHR simulator so that when you're showing this to end users or you have key stakeholders you'd like to have use the application, you can create scenarios for them to launch and have it look and feel kind of like it might be in an EHR where it's launching in embedded mode. It also, by the way, supports doing standalone mode or also B2B type of a connection. Then you can also import and create test data. As well as the part that is difficult to describe, but really very useful once you get in there, you can see is this idea of personas and launch scenarios. A persona is kind of a fictional end user. So you can build up, maybe you want your application responds differently from a cardiologist to maybe a nursing assistant, and you want to be able to test that. So you can create a persona that represents each of those user types. And then you create launch scenarios that creates a data set and context, whether it's a specific patient, location, or other parameters that the smart spec supports. And you combine your personas and your launch scenarios so that you can launch your app and really test the boundaries of how your application is supposed to respond. As it is with decision support modules and healthcare applications, it's when we hit their exceptional cases is when we really need it to shine well. And so that's why we created this thing called launch scenario, so you can hit those edge cases that maybe aren't common everyday experiences for clinicians, but the knowledge is there. And so you can have decision support modules that can help remind our clinicians of best practices, or just help them through their care. And then the other part that we really think people love about the sandbox is your ability to invite an entire team. So it's not just you that's in that sandbox and you're giving people a username and password. You can invite any number of people to jump in that sandbox. And there's different roles and responsibilities, so you can control people creating and removing launch scenarios or data or things like that, so that you can invite your end users even to come in and provide, maybe your super users to provide feedback on how your applications are progressing. And then the most exciting part about this is that Logica Health provides this as a free service, and it's an open source program to begin with. So not only is it free to use as a cloud-based service, but it's also open source, so anyone can pull down the code and use it as a starting point for a platform that they'd like to build. The other thing that I'll mention just briefly is the Logica Gallery. And the Logica Gallery is a place that where you can go and post your applications. From my experience, the Smart Gallery tends to get a little more traffic. And so there hasn't been a lot of effort into the HSPC or the Logica Gallery lately, but it definitely, there's some exciting things that Logica is looking down the pipeline as to what role it could play as this ecosystem matures. So I promised that I would talk a little bit about some of the challenges. So those are some of the tools that are meant to help get organizations, developers up to speed and running as quickly as possible to build an application or a decision support module that's ready to take into some of the EHR programs and eventually into a clinical setting. But there's some issues that you need to know about. The first is that while we talk about Smart on FHIR being write once and deploy anywhere, there are challenges in that there are variations in the support for the standard. And so as an example, there's limited data. Some use cases, some decision support modules, some knowledge algorithms require a certain base set of data, and that data may not be available across EHRs or at a specific EHR. The security and context profiles can be inconsistent from one implementation from one implementation of Smart on FHIR to the next, not because the standard is inconsistent, but just the way that it was implemented, at least early on, it's still maturing. So this means that your applications need to be aware of that, and that can be a challenge when you're creating additional complexity into your artifacts. Data can be represented in a different way. We hear about FHIR being a standard way to represent data, and while that's true, FHIR also, and it's great wisdom, and Graham's great wisdom, and that whole team's great wisdom, also gives you the flexibility to represent that data in more rich ways and different ways with extensions. And as a result, your application needs to be aware of how that or needs to know how to handle how that data comes back. And so that may mean that you may have EHR or implementation specific logic inside of your applications. And the other thing that we're seeing is that because APIs, this whole Smart on FHIR revolution has really opened up a lot of organizations' eyes to the power of APIs. We're seeing some private and proprietary APIs being prioritized over maybe some standards-based APIs. And this once again just means that if your application takes advantage of those, you're locking yourself into those solutions. So at Interopian, we've had the privilege of I don't know if it's true or not, but if I don't know another organization that has built more Smart on FHIR applications than we have, and had the opportunity to take them into production as much as we've had the privilege of doing so. And as a result, we built a platform that helps to eliminate some of those variations that we talked about. And we also have services that help organizations get their applications built and out into production and in a clinical setting quick. And so I don't have time to go through this, but really what the idea here is that the Interopio really takes and puts a faithful implementation of Smart on FHIR and CDS hooks in front of your application, so that as your application gets distributed across any number of Epic or Cerner or Allscripts hospitals, your application itself doesn't need to be aware of it. And in our data adapters, we take the time to normalize the FHIR APIs to actually convert proprietary APIs or legacy capabilities such as HL7 and others to a standard-based approach, so that your application can seamlessly be distributed across various hospital systems. We also do some things that are important. When your applications are being charged for every transaction that you're doing against the API, then you need to have a handle on that. But it's also useful to know, is my application being used, and how does it compare across sites or across regions? Or what about what type of users are using it? I thought this application was going to be used by neurologists, and now I come into my Interopio analytics console, and I see that it's actually nurse practitioners that are using it, and that was surprising to me, or whatever it may be. And so we try to provide a lot of analytics and launches and utilization and then also give you ways to aggregate that data across different areas. And then finally, it's the governance. The ability to activate your application across sites in a very seamless way is another thing that Interopio does. And then finally, a lot of organizations need help building, validating, distributing, or maintaining their applications, and that's another thing that we do and business services that we put together. We can do it because of the platform that we built. So I know that was fast. It's because we didn't have a lot of time, and I want to be respectful of the time slot that we have. But that's it. I wanted to stop and see if there were questions and go from there.
Thanks, Rick. How did you develop the sandbox, and what was sort of the nexus for building it?
Originally, when we jumped onto the Smart on FHIR bandwagon was back in 2013, and we developed the bilirubin application in a matter of a few weeks, and we did that using the Smart launcher that Josh Mandel and Nikolai Schwartner had built back then, and it was very useful. But what it didn't really allow for you to customize and build data that worked well. So we were doing a bilirubin application, which is a very narrowly focused scope of a use case that only is useful or actually relevant for the first 140 hours of a child's life. And so as we did that, we recognized that we needed our own space that we could build test data sets that we could bring developers into and share with us. And then we needed to go show it to the informaticists to make sure they were good with it, and then show it to the end users and the clinicians to see if they're using it. And that was kind of the idea. So I was actually skiing at Snowbird, and I had texted Josh Mandel earlier in the day, and Josh got back to me. And so I found a spot at one of the lodges, and we sat down, and I just started telling him a little bit about my thoughts on the HSPC sandbox. And he thought it was a great idea. I wanted to make sure I wasn't crazy. And so based off of that, I went to Intermountain Healthcare, and they were very, very supportive, Scott Naris and Stan Huff. And they were very supportive of building it. And then from there, we just used the fact that since our organization builds Smart on FHIR applications, we used our very own use cases that we needed to survive to do that. And then what we found was, as we started using it, other people started using it. And then we started getting feedback and seeing that there's a lot of commonality. And so now, here's the exciting thing. Over 4,000 people, developers now are using the sandbox today. And so we know that it's become really useful.
Awesome. Yeah, it's a great tool. And, I've had a chance to experiment with it myself, and it has lots of functionality, and it's really well done. So thanks for putting that together.
Absolutely. We were excited when we hit 50. I didn't really realize we were going to have that there would be 4,000 people so quickly jumping onto this. But I think it really goes to show that that this thing is obviously taking off, and obviously with the rules that came out earlier this week, it's now the thing. And so it's been exciting. The one thing I will say is that at HIMSS 2014, just a few months after we started doing this, I did a presentation on Smart on FHIR. And I had a whole bunch of people come up afterwards saying, this was super exciting, but you know that's never going to happen. And then we knew that we didn't have the security piece solved yet. And so then a year later, we came back and it was the same thing. It's like, okay, you're making progress on the security stuff, but once again, there's no way this is going to happen. But obviously it has. And so it's been exciting to be a small part of what this has become.
Thanks, Rick. Yeah, Mark Scrimshire commented, the logical sandbox is a great tool for HL7 DaVinci. So with that, I guess we will turn it over to Mark Scrimshire to talk Blue Button.
Awesome.
Excellent. Let me just see if I can also share my screen successfully. Come on. So hopefully you're seeing my ugly mug on a PowerPoint presentation. If I had had more time, I'd have come up with a nice pithy title like Blue Button for Medicaid, but life is what it is. A lot of folks know me. I'm entrepreneur in residence at New Wave, but I've also been engaged in the last 5 years with CMS as their Blue Button innovator and been behind Blue Button 2. There's been some great stuff that we've talked about today that I wanted to riff on e-patient Dave's famous quote of give me my damn data, because what we've really been working on is this idea of let me give them my damn data. In that what we've been doing over the last year or so, been working with Jacob Ryder and the team at the Alliance for Better Health in upstate New York, and in combination with New Wave and Videntity, we have built a platform known as Share My Health. And the whole objective of that is to enable Medicaid beneficiaries to share their data with those community or faith-based organizations that can, in some cases, save their life. So this really fits with New Wave's objective of solving for the greater good. So what really is the challenge? Well, one of the things I say is that 90% or more of care really happens in the community or the home, not in the doctor's office or the hospital. But when you're dealing with considering some of the more disadvantaged members of our community, the thing they turn to often in time of need is the EMR, the emergency room. And that's one of the highest cost places to deliver care. Yet we have a network of community organizations, faith-based organizations that can help get access to, programs that are really essential. When I was first putting this presentation together, I was planning for Orlando and nice sunny 70 degrees, but in upstate New York, it was 10 degrees overnight, and that can kill people if they're homeless. But the challenge we have with community-based organizations is that they're often working in the dark because they're not a HIPAA-covered entity, they're not a business associate, they don't have the infrastructure to operate at that type of level. And then the other thing that we have is this whole barrier to getting access to our data. So if we think about the bike as our health data, we have all of these locks, and this is not really a true picture, because in reality, our rear wheel is in Baltimore and our front wheel is in New York. The data is not in one place. But what we've tried to do with the Share My Health platform is to really create one lock that a user needs to be able to share their data with these community and faith-based organizations. And the question is, why is that such a big deal? And when we were doing some of the training with some of these community-based organizations, they came back to us and said, it's great if we've got access to this data, because in many cases we have to fill out somewhere between 50 and 70 consent forms in order to be able to get data that then allows them to help Medicaid beneficiaries apply for programs that can literally save their life. And so Share My Health is really improving the timeliness for access to data that is useful for that. It simplifies the consent process, and it also enables community and faith-based organizations, or CBOs, I'll abbreviate, to understand who else is working with a particular beneficiary. Now, one of the challenges we then have is that in some cases, these beneficiaries may not have government issued identity. They probably haven't got a driver's license or a state ID, but maybe these community-based organizations have worked with these people for a significant period of time and can therefore vouch for them. So in building an identity platform, we call it Verify My Identity, they're able to be identity verified by trusted agents in a community-based organization, in a CBO, that gives them an account. And when you think about Blue Button, and I really have to take hats off to CMS and the work they've done with Blue Button 2, because they made the process of authorizing sharing of data that much simpler using OAuth 2, that is now really enshrined in the rules that were released this week. Well, you can't authorize the sharing of information if you can't identify yourself. And so Verify My Identity allows a beneficiary to have an account that they can log in with, and then they can then choose to share their data with any of these CBOs so that they can understand the health data that they're dealing with. And so what we're doing is we have connected to the local health information exchange. We are converting CDA documents into FHIR resources that can then be presented to both the beneficiary. They can go and see, the procedures, the vital signs, the lab results, and so on that have been presented. But they can also then choose with the click of a button to share that information on to one or more of their of the CBOs that they might be working with. It may be to help provide them with a roof over their head. It may be to provide them with access to a food pantry. It could be to a whole range of other services. And one of the byproducts there is that these agencies can see which other CBOs or faith-based organizations are working with that individual. And so they can try and coordinate then their plan of action to try and help the individual. The other thing I really want to do is give a shout out to Jacob Ryder and the Alliance for Better Health up there in New York, because one of the things they insisted is that the software that's been developed is actually open source. You can go and find it today on GitHub under the Transparent Health account. And we have a number of components, including the software to deploy this into an AWS cloud. And it is available for others to use. And we built this on top of standards. Verify My Identity is a certified OpenID Connect server. The OAuth hub that is then handling the sharing and the conversion of data from the local health information exchange is actually the same code that was used as part of the Blue Button 2 solution at CMS. And then we built the Share My Health application as a front-end web application that can run on a smartphone or on a laptop or on a tablet, so that the agents in a community-based organization can do that identity verification. They can help the beneficiary create their account and then help them through choosing to share their information. So I've run through that really quickly so we can actually open up for questions. I'm happy to answer any questions that we have here. But we can also, New Wave, we were planning to do a longer podcast where we can go into this in more detail, and I'll certainly be happy to share that information once that's produced. So, Adam, I don't know if you have any questions that people were posing.
We don't have any questions, but I think this is definitely worth some further discussion. I think in the sake of time, we're running behind. So
Yeah.
I think we'll go ahead and wrap it up and hand it off to Dr. Ken Mandel.
Yep. So thanks very much. I would say if anyone is interested in deploying this in other parts of the country, that would be absolutely fantastic. We would love to talk to you about it.
Yeah, it's some great work, Mark. I would love to actually learn more. So
great. Thanks very much.
And so, yeah, last but not least, we have Dr. Ken Mandel of Boston Children's Hospital, where SMART was invented and created. And Ken has a great story of how this started, and I'm sure a lot of thoughts in regards to what the future holds that I'm eager to hear about. And Ken, you might want to go off, come off mute.
Yep, I'm off mute. I'm going to share my slides for a moment and go here. Okay. Can you guys see those slides?
We've got your slides, Ken.
Excellent. I'm going to jump right in and I'm going to zip through these slides. A little bit of the history of SMART, and I'll peek into the future at the next set of challenges. And Adam, thank you very much for, as always, bringing our community together for this webinar. I'll run through this diagram that's on the front page of the Smart Health IT website and take us on a whirlwind tour from the beginnings of SMART with a 2009 New England Journal of Medicine paper that I wrote proposing that we have a universal API for healthcare, health apps, and App Store for Health as an adjunct to the $48 billion investment under the Meaningful Use program in electronic health record infrastructure, all the way up till this year and this week's finalization of the ONC rule, instantiating the Smart on FHIR interface, both the one-at-a-time API and the Smart Bulk Data API as universal standards for interoperability in healthcare. So let me start with a quick use case. We ended up with funding from the Smart Health IT program, and we started to think about apps that we could develop. But even before we had that funding, this was an app that we had kind of imagined developing. It's a prediction. It's a predictive medicine app from 10 years ago. And what it showed was that we could actually detect domestic violence up to 2 years before the emergency department visit for it, where it was recognized by the healthcare system. 2 years in advance, we could identify issues of domestic violence through deep learning of a healthcare data set. But to implement this in a healthcare system would be very tricky. It would take a dedicated CIO probably a year, and then it wouldn't be particularly transferable. So while we had this algorithm and we had a high impact paper that got press, the British Medical Journal is a great journal for it, the impact on practice was nothing. And that's because we can't bring at scale algorithms, data visualizations, data mashups into the health system. It's a one at a time proposition. One issue that we faced all along is that data are not interoperable and neither are the systems. So here's an example from another industry. This is a Keurig coffee story. When Keurig was acquired by Big Coffee, Green Mountain Coffee, they broke the interoperability of Keurig, and they made it so that an off-brand Keurig K-Cup would not play in a Keurig machine. Hackers came in and taped a cut-out piece of the code from a branded cup to a non-branded cup, and it would play in the Keurig machine. And I would argue that this is what folks who have made things work in the healthcare system been doing. This is what we've been doing for decades to get things from one institution to play in another institution. And the opportunity that we faced with SMART was, how can we make this just happen at scale as a fundamental property of the healthcare system? So there was a $48 billion investment in health information technology under the Meaningful Use program. At Partners Healthcare in my neighborhood, about $2 billion was spent on Epic, and we think north of $500 billion has been spent by private sector investment on the implementation of electronic medical records. And one issue is that they were purchased at their peak of inflated expectations, and then folks got a whiff of kind of what you actually can do and can't do. And we've been making our way up a plateau of productivity. This is the Gartner hype curve. And I would argue that this ONC rule will accelerate our climb up to that plateau, and perhaps even ultimately exceed our expectations of what these technologies can do. But right now, as of today, much of the point of care remains a walled garden, very difficult to integrate with. So when that $48 billion investment was first proposed, we wrote a piece in the New England Journal. It suggested that there be an API for healthcare, universal API, and that API be vendor independent and enable an app to be added or deleted to an electronic health record as easily as the iPhone. And the iPhone was only 1 year old. So it got people's attention because they were learning in our article often about the iPhone itself and also about how that model might serve healthcare well. So why would you do this? Well, one, so that innovators, and I heard Ricky Freeman on there, could get to the point of care at scale very quickly without worrying about each one-off integration and app store model for health. A second reason is that clinicians could get customized visualizations and experiences in their health record through apps. And a third is that the apps can compete for each other on price and functionality and usability and all those things that we don't see evolve as quickly as we would like in the current electronic health record environment. So we were actually funded very generously by the Office of the National Coordinator to produce SMART on FHIR. And we kept our eye on the prize of this very narrow goal, which was to have an API that would enable apps to be added or deleted from the electronic health record, a property we call substitutability. Substitutability is the key yardstick for whether you're interoperable or not. The app shouldn't have to know anything about the underlying infrastructure locally. It should be presented with the same data each time, the same way. So we asked in this project, can electronic health records behave like iPhones or Androids in that innovators readily create and widely distribute substitutable apps across thousands of installs, and that requires an API. The first thing we did to get this API designed was to create a candidate version of it and then to actually try it against a real app. We were inspired by this data visualization that came from Wired magazine, who looked at the current laboratory information systems for reporting out results, and imagined through commissioned artwork what future states might look like. This cardiac risk app, imagined by Dave McCandless and drafted here as an image, but as we say, fully operational in Photoshop, we took, and our developer in 1 week turned it into a actual smart app, pixel for pixel reconstruction, pulling all the data across the electronic, from the electronic record across the API. And here it is, very early in our project, running unmodified across 3 open source electronic medical record systems. The R in SMART is reusable, and this shows the app as reusable. We added it to these systems, it's substitutable, and it runs across multiple systems, it's reusable. We had a contest that Anish Chopra asked us to hold on whitehouse.gov. He was early in his role as Obama's appointee as the US Chief Technology Officer. The company that won was called Polyglot. We continued to work with them. They had a great application, medication instructions, user-facing, patient-friendly, 22 languages. It took them 48 hours to turn their resource, incredible resource, into a smart app. Great commercial success for this company. They started asking for integration via the Smart on FHIR API before the Smart on FHIR API was implemented anywhere. Polyglot taught folks how to do it. They started to drop their integration costs over time. We wrote up in JMR the story of this commercial success. They were acquired by First Data Bank and are a going concern, integrated across multiple EHRs, patient-facing and physician-facing versions. In the app stores of the electronic health records, in the smart app gallery as well, and doing very nicely. At home, we created the first functional smart app at Boston Children's Hospital. Patients' blood pressures plotted over time, adjusted for age and percentile, critical in the field of pediatrics, functionality unavailable in electronic health records, who at the time didn't even have weight-based dosing for pediatric patients. We did a similar play for a growth chart with a very nice, I think, graphic sense. We had a graphic designer do this. The electronic health record saw this and said, hey, you know, this looks pretty nice. Maybe we can run this. This is running across multiple pediatric institutions now. We started to do genomic mashups. This is 23andMe data against electronic health record data with risk maps. It shows you how quickly you can get to genomic medicine using these interoperable technologies. Vanderbilt went to town with it and created precision medicine cancer apps, and they continue to use this innovatively in their clinics. We started to get into the decision support space, and this shows an app that sends immunization data up to a server in the cloud, which a rules engine, which runs the CDC immunization rules and forecasts back what immunizations you need next. CDS hooks is standardized technology now, ready for adoption, that actually triggers when you call a third-party decision service or triggers when you run an app. We have an app gallery funded by the Office of the National Coordinator. It's open and free. And our sandbox has been used across the industry for developing Smart on FHIR apps. In some cases, it's been replicated. In some cases, the big technology companies and others have just used our sandbox directly. The nice thing about this app gallery model, which is, I'm going to say somewhat tongue-in-cheek, better than the Apple App Store and better than Google Play is that it actually has data underneath, so you can demonstrate the apps and actually use the sandbox to develop them as well. So interesting things happened. Meaningful Use 3 required that there be an API for patients to access copies of their data. This is the patient empowerment piece of this. And the opportunity here is to all of a sudden have standardized an approach to this. And the regulation caused the Argonaut group to come together, electronic health record vendors, HL7, us, others, to implement the Smart on FHIR API across the electronic medical record systems. Almost as soon as this was done, Apple managed to use these new FHIR endpoints, all standardized through the Argonaut process, to connect its health app across hundreds of health systems where patients can download computable copies of their data across the Smart on FHIR API. This is the capability of the health records function in the native health app of the iPhone being announced on the stage at the Apple Developers Conference. Dr. Rucker asked us to develop a population analog to the API for SMART, and we did. Working with HL7, we created the SMART HL7 flat FHIR bulk data export API. And amazingly, while the original SMART took, as I showed you on that diagram, 10 years to get all the way to the, all the way from sort of idea to regulation, the push button population health or the bulk data export, 6 months, and CMS was using it 2 years to from conceptualization to being instantiated in the rule. We're very proud of having delivered that piece of interoperability, as all the other Smart on FHIR products have been. Open specification, liberally licensed, and adopted widely by industry and standardized through HL7, and now standardized widely. I don't do much lobbying, but I did manage through conversations in one afternoon to get a few phrases into the 21st Century Cures Act. And the key here is that an API is required to provide access to all data elements of a patient's electronic health record without special effort. Dr. Rucker, Steve Posnack, and the ONC team took those sentences and created the, as you know, much longer but extremely thoughtful rule that implements interoperability and also information blocking and makes the Smart on FHIR API and the Smart HL7 bulk data API both available and required and standardized for use in healthcare. So I published a piece this week tied to the timing of the rule. Dr. Rucker and I enjoyed a paired set of commentaries in the New England Journal looking at this achievement. And let me talk to you very briefly in the remaining minute or two of this time about the about where I think we need to keep our eyes on the ball for the next steps. I outlined in the rule not only the great achievement of the API, which is about interoperability, where ONC took its remit and maximized its impact by finally getting us into an interoperable environment. They do not regulate HIPAA and other privacy laws and regulations. And so we now have to pick up the baton and think what's happening in the future. These are 4 challenges that we discuss in the New England Journal piece. One is predatory app companies. This has been a concern that actually we discussed, Dan Gottlieb, Josh Mandel, and I in a blog last year. It's been pointed out in the run up to the rule being announced that patients may be enticed to give their data to an app whose company does not have their best interests in mind. It's important to know that when the data are in the healthcare system, they're regulated by HIPAA. When the patient requests those data to come across the API into a consumer app, they become regulated by the FTC. The FTC can only enforce the terms and agreements that are that the patient agrees to and clicks that they agree to, and there's an opportunity to create an experience for the patient there, which is transparent, clear, and supportive of their autonomy, but also protective. There could be an emergence of a non-market economy. The price that electronic health records pay for electronic access, for API access, the price that is charged will have a big impact on whether apps can actually make a living. And if apps can't make a living, then we won't get the market that we hoped for. There are other potential risks to the market, and that is that there may be companies that use the API to create a second layer of proprietary walled gardens. And while that may be a legitimate business model and allowable under the current regulation, I believe that we should watch that very carefully and make sure that those models are still consistent with a free-ish market for competition between apps and maximum selection of which apps patients and providers are able to choose. There are possibilities of other abuses and breaches. Cybersecurity will always be an issue. A big cybersecurity breach early on in this field would be harmful to the overall ecosystem. And finally, we point out the digital divide. Not all patients have the level of literacy or the level of technology literacy to use these APIs effectively. In my opinion, much of the benefit to patients will happen through their permissions and through the introduction of data-driven processes in healthcare and the application of machine intelligence in healthcare and decision support and communication across sites of care. But patients who will often be asked or required to report outcomes, to share data, or to be reminded to be beneficiaries of behavior change programs that make them healthier. And we need to be very conscious of the digital divide. I will just point out that in the setting of coronavirus, I am reminded of a piece I wrote, putting the smart health IT, the Smart on FHIR API into context from what we learned from Ebola. We were fortunate to have only one case of Ebola come to the United States then. But just think what electronic health records should be able to do for us by now in the coronavirus and how little we're able to rely on them currently for the management of this very serious pandemic. I'm hoping as we get through this, we get through this much more easily than the worst case scenarios, and that we are motivated to make sure that the next time something happens, we are in much better shape. Again, thank you for coming with me on this brief tour through the last decade of SMART. And I'll let people get on to their weekends and turn it back over to Adam.
Thanks, Ken, for taking time out of your schedule. I know I'm sure lots of work happening up at Boston Children's to prepare for the coronavirus outbreak. But one of our speakers, Shahid, has a few comments on some of the work he's doing that we'll let him share. But thanks, Ken, for joining us. Excellent story, and it's been neat to be a part of the journey from even in the latter part of the curve, to see SMART go from idea to reality. And so it's been a fun ride.
All right. Well, thank you for everything you've done, Adam.
Thanks, Ken.
Bye now.
Yeah, thanks, Ken, and to the rest of the speakers as well. So my job is to just kind of summarize the day that we've had today. And I wanted to start that off by talking about how developers that I've been speaking to, but this is a little bit of work that I do with hospital innovation teams, as well as with local, federal, and state governments. There are a lot of developers that are hoping that they can help with the coronavirus. And so Josh just mentioned COVID a little bit, but we haven't talked about it most of the day in our conversations. But one thing to be recognizing is that going up to our hospitals, administrators, government, et cetera, and just taking your technology and going to them and saying, okay, how can I help you? Here's my tech. You please figure out how my tech applies to you, is a horrible way of trying to be helpful. What we need to do as developers is to step back for a moment and say, well, what are the biggest needs at the moment for COVID? And unless you are doing COVID diagnosis, currently the only way to do a proper diagnosis through standard of care is a PCR test. And there are no other well-known techniques. If you have one and you can easily describe it as a top-notch diagnostic, please definitely do so. If you have technology that can help with self-triage and help consumers make decisions about whether or not they need to see their doctors, those are good. Do you have any personal care assistance or urgent telehealth or urgent care telehealth or related therapeutics? Those are all good. But the vast majority of technologies out there are not going to be helpful. And in fact, what you're going to end up doing is accidentally confusing the hospitals and health systems, which are already going to be very busy trying to take care of patients, by offering your solutions, which may or may not have a direct impact. So the best way to do it is to classify these into two ways. If you have a technology that you are very crisply and clearly understanding that can help with diagnosis or therapy of COVID, that's great. But there are going to be very, very few of those. You, however, might have lots of technologies that could help alleviate the real burden. So the worried well, telehealth, being able to take technologies and put them into place so that our hospitals and health systems can focus less on the worried well, focus less on the people that are going to be not really sick, but are going to be burdening the systems. So it's okay that you don't have a direct technology, but I'm being implored by health systems and others who are seeing innovators come up to them and saying, here's my tech, how can it be used in your environment? Instead, try to figure out what is the best way that can be put into use and tell them about it. And that will actually help them reduce their workload and start to take care of these patients that are going to start to tax the health systems. With that, I'd love to have the speakers. I'm going to just thank everybody. If you guys come on the video, we can thank you guys all for coming and speaking about all kinds of different topics today. There's cloud topics. There are, we talked a lot about FHIR and other capabilities, and we're hoping that this continues. And so you're going to see many emails from Megan over the next couple of weeks as we summarize what's going on in the environment. And if you have questions, please send it to us. I think because these are going to be very virtual, answering questions over time virtually is going to be really, really good. One of the other complaints that I've been getting from our governments as well as healthcare systems is people are giving advice on the obvious. So stuff that is already on CDC and other places, there's no need to come back and rehash the exact same thing that is being done elsewhere. Instead, what they're looking for is prescriptive guidance that says, use this technology in this specific way to help you in these particular techniques. So if you've got any prescriptive ideas around plans and techniques and processes and procedures that health systems and governments can start to play with, definitely offer those as well. So with that, I'd like to turn it over to Megan. Is there anything else you wanted to say before we close up? And you're on mute, Megan.
Well, I wanted to thank everybody, especially Adam, who's been a great partner in this, and Shahid, and Matthew, as well as the folks from Onyx. If everybody wants to come on and turn on your video, all the panelists that have the ability, we'd love to get a group shot and sort of take a bow. This was our, first adventure in this virtual event world, and I think we're all pretty happy with how it came together. We know it was last minute, and certainly, everybody was super flexible and wonderful to join us. So, Dave's still around, great, and we had great engagement today. We had over 100 people, online in the Zoom. We had several people register, just in all day long, and so it's been really great to have all of you. So take a bow, take a screenshot, and we look forward to really doing this in the future, and certainly building upon these topics. And anybody can share and say anything they like now, and I'm going to actually take a screenshot with my phone and with the computer. So, being a total dork with the computer, the phone in the phone. All right. Adam, did you want to say anything to close us out? Oh, you're on mute too.
No, thanks. I mean, really, Megan brought this all together. So thanks, Megan. Thanks for including me. It was a good event. ePatient Dave, great passion, and just very pertinent topic. And stay safe, and hopefully this coronavirus craziness will we'll get through this soon.
Yeah, absolutely. And I should thank Matthew Holtz as well for helping us get it on YouTube at the last minute with a little technical difficulties, but we did it. So
next time you can do it yourself, because now you're legit to quit.
Right. I should be
legit enough not to quit enough or something. And
24 hours it took. So now we're ready. So next time.
Matthew, I must say that I was not shocked when you had to ask what those medals were hanging on David Lee's wall there. I know you're not too familiar with running medals yourself.
You are to the Bronco. I'm on Couch to 5K week number 4. I'm about to go out and do my first 3 times 5 minute run. If I survive the experience, I guess I'm gonna have my heart attack quickly while there's still some capacity in the system.
No, that's terrific. That's how I beat pre-diabetes. Good for you.
Well, thank you all. Enjoy, and please stay well. And it's nice to not be quite so socially isolated. Hopefully we can do this again soon.
Thanks, Megan. This was wonderful. And Adam and Matthew and Indu. Thanks so much for doing this for us.
Yeah, thanks very much.
Absolutely.
Excellent.
Thanks, everyone.
Everyone.
All right.
Bye.
Bye.